So good evening everyone. If I'm visible and audible, please give me a thumbs up guys. I'm looking at the messages and then we'll start from there. Okay. Welcome to this FMGE Predictor Series 2026. So I'm just looking at the messages. Thumbs up from someone. Yes guys. Please give me a thumbs up. And in that case, I'll start. Okay. Hopefully I'm visible and audible to everyone. Okay. All right. So let's start with the session. I would prefer that if you people could answer it. Okay. So I got thumbs up from Dr. Shweta and Dr. Kaivalya. Good. Chalo. Without wasting any time, we are discussing anesthesia, guys. Okay. And this is the FMGE Predictor Series 2026. Let's go with the first question. All of you already must be having the question. Good evening, everyone. All right. So the first answer. The question is, a patient with dental problems is assessed pre-operatively for airway evaluation. On mouth opening, the hard palate, soft palate, entire uvula and tonsillar pillars are visible. So good evening everyone. I can see good evening from all of you. Yeah, good evening guys. Okay. On mouth opening, hard palate, soft palate, entire uvula and tonsillar pillars are visible. What is the correct interpretation of the Mallampatti score in this patient? A. Type 1 easy intubation, type 3 easy intubation, type 1 difficult and type 3 difficult. If you can see the image. In the image, you can see the complete uvula. As soon as you see the complete uvula, I think everyone has given me the answer 1. Okay, correct. So here the correct answer is option A, type 1 easy intubation. So when you're speaking about Mallampatti, this is one of the most important questions that comes in the exam. I'll not go into too much details. We'll try to finish off fast. So remember, whether it is Mallampatti 1, it is Mallampatti 2, Mallampatti 3 or Mallampatti 4. The point is just look at the uvula. If the complete uvula is seen, it is Mallampatti 1. If the tip of uvula is not visible, okay, tip is not visible, it becomes Mallampatti 2. If only the base of uvula seen, Mallampatti 3. And if uvula not seen at all, it becomes Mallampatti 4. Simple point to remember, Mallampatti 1 and 2 are supposed to be easy intubation. Mallampatti 3 and 4 are supposed to be difficult intubation. Correct? Because they correspond to the Cormack-Lehan grading. Mallampatti 1 corresponds to Cormack-Lehan 1. In Mallampatti 1 and 2, what will happen is vocal cords would be seen. Mallampatti 3 and 4, vocal cords are not seen. So therefore, easy intubation and difficult intubation. Clear? Dhanu bhai Ram Ram. हमारी तरफ से भी Ram Ram. Okay, good. Everyone is giving that answer. Even I said Ram Ram. Nice. Clear everyone? So this question, Mallampatti, is one of the most important questions. You ask the patient to open the mouth, extend the tongue, do not phonate. And what we are doing is looking at the posterior pharyngeal structures. Remember, apart from the uvula, what other structures should be present? This is the uvula which you see. Okay. Apart from the uvula, what other structures? This is the uvula. Okay. Apart from the uvula, you will see the tonsillar pillars. These are the pillars. Okay, there are the tonsillar pillars. This area which you see over here, these are called the fosses. Fosses. Here is the soft palate and here it is the hard palate. So in this image, you can see everything. The uvula, the tonsillar pillars, the fosses, the soft palate and the hard palate. And therefore, this is basically Mallampatti 1. Okay, Dr. Dhanush says zero epiglottis visible. If you can see the epiglottis over here, normally, which is not seen. If you kind of see the epiglottis over here, that becomes Mallampatti class 0. Okay, that won't be asked so much, but rest remember, in case of Mallampatti 1, if you can see epiglottis, it is called Mallampatti class 0. Let's go to the next question. Okay, identify the needle shown in the given image. So these are all based on recent questions. Questions like these have all come. Yes. So you can see a needle in front of you. There's a needle right in front of you that you can see. Options given are Quincke spinal needle, Toohey epidural needle, Huber needle and Verey's needle. What's the answer over here? All of you, simple question over here. Is it Quincke, Toohey, Huber or Verey's? The answer is, you can see this needle, it has got 1 centimeter marking. This needle has 1 centimeter markings. Why? So that you know how far you are from the skin. I think everyone has given the answer B. D नहीं है, किसने आंसर D दिया? कोई एक आंसर D भी दिख रहा था मुझे, नहीं करेक्ट हुआ, करेक्ट B. B is the correct answer, guys. Don't make mistakes in the exam. As I said, the students preparing for FMGE, all of you are well read, well prepared. Don't do. Sweta saying, it's okay, fine, it's fine. But that's what I'm saying. Don't do silly mistakes in the exam. My only point is don't do silly mistakes. All of you nowadays, I am finding FMGE students are well read, they are well studied. Silly mistake वो होता है when you don't read the question, you think you know the answer and you mark it हाँ, overconfidence. No, not overconfidence, maybe not, just the tension of the exam. Don't get tensed out. All of you are well read, well studied. Just maintain your calm and composure in the exam. All of you. I'm telling you, that's the only point. Last exam also, we've had students who have scored 213, 220, 218, right? So therefore, just do not panic in the exam. Same thing here also. All right, this is just a revision. We'll do it fast. Now, Quincke spinal needle, remember, this is when you speak of spinal needles, there are of two types. This is the epidural needle that you can see. It has got 1 centimeter marking. This tip that you see over here, this is a curved tip. And this curved tip is what is called as Huber tip. There is no Huber needle per se, but इसको बोलते हैं curved tip or Huber tip. This is the epidural needle which you can see. Okay, so this is the epidural Tuohy needle. Now, when you speak of spinal needle, and comparatively you will find this needle is much more thick. T for Tuohy, and this is a thick needle. Why it's a thick needle? Because from here you are going to pass a catheter inside. Okay, so comparatively you will find that the needle is thick. All right, it is called Tuohy needle. When you see a spinal needle, okay, because this has also been asked in exam, the spinal needle is basically of two types. You will find one of them is dura cutting, and that is the Quincke. Okay, that dura cutting is Quincke. The tip of that needle is like this, right? So what it does is it gives a bigger rent in the dura, and this leads to more damage in the dura and more PDPH. Compared to that, you have a dura separating needle. Dura separating is Whitaker, या Sprott. Dura separating is again basically called a pencil tip needle. Pencil tip needle. Okay, so it is like this. Pencil tip needle is like this. Okay, so the pencil tip needle is going to leave a small thing like this. This causes comparatively less damage to the dura. Okay, clear? Okay. Dr. Dhanush says PDPH. हाँ, correct. More damage मतलब more PDPH. Correct. More incidence of PDPH. Absolutely correct. Less damage means less incidence of PDPH. Dr. Dhanush says correct. Okay, absolutely correct. Now, so we have seen the needles. We have seen the epidural needle, which is the thick needle. We have seen the spinal needle, the dura cutting and the dura separating. All right. Now, Verey's needle is the one which is used in surgery. Okay, this is a wrong name. This is a wrong name. Huber needle नहीं होता, Huber tip होता है. And Quincke spinal needle is the dura cutting needle. All right. So we have done with these revision of the options as well. Fine. Any questions and doubts, guys? You can ask me. Now, next one. All right. So we have seen these needles. Question number, next one. Which of the following statements is incorrect regarding the equipment given below? There's equipment that you can see. All of you first need to identify the equipment in a question like this. The equipment that you can see is a laryngeal mask airway. Okay. LMA. So therefore, based on that, it has been asked, it is a classical LMA. LMA was first described by Archie Brain. After correct insertion, it crosses the vocal cords. It can permit positive pressure ventilation up to 20 centimeter of water. So when you speak of this question, many times you might find a question like this coming in the exam and you will feel, oh, I don't know anything. As I said, anything, calm down, don't panic and think what you already know. We'll see one by one the options. Even if you don't know the answers, how to rule them out. Is it a classic laryngeal mask airway? Yes, you guys know that this is true. All of you know this is true. Okay. Dr. Dhanush says C. Haan, Dr. Dhanush, correct. The correct answer here is C. That is the incorrect statement, right? Here we had already seen this is the incorrect statement. The second point is LMA was first described by Dr. Archie Brain. Yes, this is also correct. Now you see the third option, after correct insertion, it crosses the vocal cords. Vocal cord cross means it is crossing the trachea. Do you think a laryngeal mask crosses the trachea? The name is only laryngeal mask airway. Laryngeal mask airway means it lies in the larynx. It lies in the larynx means it lies outside of the trachea. It lies outside of the trachea means it does not lie in the trachea. So if it does not lie in the trachea, this becomes the incorrect statement, because after correct insertion, it crosses the vocal cords. No, because if it crosses the vocal cord, it will go inside the trachea. That becomes the wrong statement. Clear? All right. So I think everyone is giving the correct answer. The fourth, again, yes, you may get confused about this, but this is also a correct point, that it can permit positive pressure ventilation up to 20 centimeter of water. Yes, it can. If it becomes more than 20, then there are chances of leakage and aspiration. Okay. If it becomes more than 20, only then there is chances of leakage and aspiration, but don't go into too much details of that. Even with this much, it's sufficient that you can answer the answers. Okay. Above esophagus place करते हैं, says Dr. Smooth Specialist. Correct. Absolutely correct. Above esophagus ही place करते हैं, एकदम correct. ठीक है. इनफैक्ट एक और क्वेश्चन यहाँ पे आता है above esophagus में. Let me write it down, that the tip of the laryngeal mask airway, ये tip, this lies at the esophagus. Okay, remember this. Tip of the laryngeal mask airway, it lies at the esophagus. One more point that I will discuss about the laryngeal mask airway is that, remember, laryngeal mask airway nowadays are classified into two types. Okay, and that is the first generation and second generation. Remember this point. First generation and second generation. Exam it can be asked as an image based diagram. First generation will have one tube, second generation is going to have two tubes. One tube means it's going to have only one airway tube, what you see exactly in front of you. This image that we see is basically first generation LMA. This is first generation LMA because all we can see is one tube. I can see only one tube over here. Okay. Now, when you can see two tubes, it is called second generation LMA. Here you are going to get airway tube. Apart from that, I'm also going to get a drain tube. The biggest advantage is that this second generation LMA helps to decrease chances of aspiration. Helps to decrease chances of aspiration. Therefore, used for IPPV. मीन्स पॉजिटिव प्रेशर वेंटिलेशन. फर्स्ट जनरेशन में क्या होता है, चांसेस ऑफ एस्पिरेशन है, काफी ज्यादा है, लॉट्स ऑफ एस्पिरेशन. देयरफॉर यूज्ड ओनली फॉर स्पॉन्टेनियसली वेंटिलेटिंग पेशेंट्स. स्पॉन्टेनियस, जो खुद से सांस ले रहा है, स्पॉन्टेनियस ब्रीदिंग पेशेंट्स. I think you already know it. We'll just enumerate the names because that has also been asked in the exam. So therefore, you will have four names in first generation. One is classic LMA. Second is intubating LMA. The third that you can see, that you know, is flexible LMA. And the last is unique LMA. On the other hand, when you speak of second generation, you are going to get something called as a ProSeal LMA. You are going to get ProSeal LMA. The second one is a Supreme LMA. The third one has not been asked in exam, but it's very important because iGel is a cuff-less LMA. There's no cuff. And the last one is Ambu Aura Gain. These are 4 second generation. Rest all are first generation. Clear? Dr. Dhanush says second gel is iGel Supreme 40. Supreme is first. No. LMA Supreme is second. No whosoever. नहीं Supreme LMA is second generation. उसमें drain tube होता है. Dr. Dhanush. नहीं, Dr. Dhanush नहीं. किसने लिखा था? कट गया. Dr. Kamil says, sir, how are you? Thank you so much, guys. I hate images of LMA. क्यों यार? Don't hate images. These are simple. Remember, just look at the number of tubes. It's going to be simple. Normally, I'll tell you again, in exam, they won't ask you other things. They'll ask you ProSeal. They may ask you iGel at the max, Ambu that asked once, and Classic at the max. These are the normal images that they've asked in the exam, not more than that. Okay? Normally, these are the images of LMA that they've asked in the exam. Clear? Next question. All the following statements are true about the mask given in the picture, except. Wait, sugar nahi hai. No sugar. Sorry for that reaction. I didn't expect sugar. Remember, sugar is needed In the drug also. Tell me fast. Who will tell me? In which anesthesia drug is sugar present? If anyone remembers. Okay, fast. This question is not here as a part of this. Okay, which anesthesia drug contains sugar? And that is been an exam question. Of course, it's not a part of this over here, but Dr. Smooth Specialist says ये मुझे याद नहीं होता. अरे याद हो जाएगा. Ambu Aura 40 Dr. Ronak is asking me. Ambu Aura 40 क्या होता है? Ambu Aura 40 फर्स्ट जनरेशन होता है. अंबू के जितने भी हैं दे आर ऑल फर्स्ट जनरेशन और बुक्स में गलत लिखा है. सम प्लेसेस दे मस्ट हैव गिवन. डॉक्टर स्मूथ स्पेशलिस्ट है सिवोफ्लोरिन. किसी को पता है? मैं किसी ने मेरा अटेंड किया हुआ है सिवोफ्लोरिन वाला. हाँ, पीपल नो सिवोफ्लोरिन. सबको याद है? ऑल ऑफ यू नो सिवोफ्लोरिन? नहीं, आज सिवोफ्लोरिन नहीं मिल रहा है मुझे. सिवोफ्लोरिन नहीं यार, क्या चीज है? विच इज स्वीट. हाँ करेक्ट. हाँ दैट इज राइट यार. ऑल यू गाइज हैव सेड सिवोफ्लोरिन स्वीट स्मेल. गुड यार, गुड. आई एक्सेप्ट इट. नाइस. So very nicely said. Sevoflurane, sweet smell, but it does not contain sugar. But if you remember, we have discussed in classes also. Do you remember when we give bupivacaine for spinal anesthesia? Anyone remembers? Bupivacaine for spinal anesthesia contains dextrose. Do you remember this point? So that it becomes heavy and the drug settles down. Do you remember this point? Bupivacaine for spinal anesthesia contains dextrose. That is what I was referring to. Okay, if you remember. Otherwise, sevoflurane being sweet smelling, absolutely correct. Being sweet smelling and a bronchodilator, it is used for pediatric patient. Dr. Girendra Pal says bupivacaine. Correct, absolutely correct. Bupivacaine for spinal anesthesia is what contains dextrose, so that it becomes heavy. Specific gravity of the drug becomes more than specific gravity of CSF. It settles down. That's the point. Okay, so chalo, that was a deviation from here. Let's come back to the question. I think I've answered all the questions which you had asked me. I can't go back because the television is far away from here. So I can't see. I can't go back and read the previous messages. Let's go to the next question. All of the following statements are true about the mask given in the picture except. There is an image that you've got, right? There are 4 options which are there. It has a triangular body. Can you see this triangle? Haan. It is used in pediatric patient. Haan. Dr. Girenpal says, sir, I'm OT technician. अरे great. वेरी नाइस डॉक्टर गिरेंद्र. अच्छा बोला. गुड गुड गुड. इवन देन ओटी में काम किया है, थोड़ा पता चल रहा है. वेरी नाइस. बहुत अच्छी बात है. वेरी नाइस. वेरी गुड टू सी. अटेंडिंग, गेनिंग नॉलेज, अच्छी बात है. वेरी नाइस. वेरी हैप्पी विद इट. वेरी हैप्पी. मेरे को कॉन्टैक्ट भी कर लेना, हॉस्पिटल में जरूरत पड़ेगी तो वी कैन हैव. ओके, नेक्स्ट हम लोग डिस्कस कर रहे हैं अबाउट द मास्क गिवन इन द इमेज. सो एज यू कैन सी, द इमेज दैट यू सी इज ट्राइंगल इन शेप. इज इट ट्राइंगल? यस. Is it used for pediatric patient? हाँ, छोटा छोटा दिख तो रहा है. You can see it small. So it is used for pediatric patient. It has a triangular body. Correct. It has a low dead space. We don't know. But 4th point, contraindicated in patients with tracheostomy. Tracheostomy means it is cut over here. Right? So why will it be contraindicated in a patient with tracheostomy? And being small, yes, it is going to have a dead space which is less. So therefore, all the following statements are true except one statement which is false, and the false statement is not A, B and C. The answer is D. Okay, the answer is D. ठीक है. So let me tell you now. Wait. When we were talking about this, it is a triangular body. Everyone agrees? Yes. Predominantly used for pediatric. Yes. तो pediatric बच्चे का face भी तो छोटा होता है. So compared to adult, it has low dead space. Let me complete this sentence. It will become easy. Compared to adult mask or different mask. Compared to adult mask or a bigger masks. Remember, dead space क्या होता है? Dead space is, Dr. Smooth Specialist says, what is this answer? हाँ, let me tell you that. Low dead space. जब भी हम लोग कुछ मास्क रखते हैं, whenever, what is the meaning of dead space? Dead space is any area which contains oxygen and not taking part in gas exchange. So if I take a mask like this, I've taken a mask and put on my face. Can you see this? If I put a mask on this face, it contains oxygen. So this is going to increase my dead space. This area is not taking part in gas exchange. It has increased. On the other hand, if I take a small mask and I keep it on the face, can you see this? Compared to the bigger mask, the smaller mask has less dead space because this is containing less oxygen. Is this clear, everyone? That's why the answer C is not correct. It is going to have a low dead space. It is means low dead space होगा उसमें. It's going to be there. D is the answer. अगर किसी को tracheostomy होके रखा है, किसी को, आई वॉन्ट टू कीप ऑन स्माइलिंग एंड लाफिंग बट फॉरगेट इट, लेट मी फिनिश ऑफ द पॉइंट्स. अगर किसी को ट्रेक्योस्टमी होके रखा है, व्हाई विल अ मास्क बी कॉन्ट्राइंडिकेटेड? टेल मी दैट. थिंक अबाउट इट ना. समटाइम्स यू, दैट्स व्हाट आई एम सेइंग, डोंट पैनिक इन द एग्जाम, थिंक अबाउट व्हाट हैज बीन गिवन. एग्जाम में ऐसे क्वेश्चंस आते हैं. इफ देयर इज अ ट्रेक्योस्टमी ओवर हियर, right, tracheostomy is there, why can't anyone hold a mask on the face? Is there a contraindication to hold a mask? No. So contraindication is not there. So contraindicated in patients with tracheostomy? No. ऐसा कुछ नहीं है. अगर किसी को tracheostomy mask पकड़ो ना, कौन मना कर रहा है? But it has a low dead space. ये जो point है, ये true है. It has a low dead space. Yes, it is true when it is compared to an adult mask or when it is compared to a bigger mask. Because the biggest problem of a bag mask ventilation, if someone asks you anytime, bag mask ventilation का biggest disadvantage क्या है? It increases dead space, and that is why you get one question. What airway device decreases dead space? Again, this is an MCQ question. What decreases the dead space is basically tracheostomy and endotracheal intubation. Right? If you do a tracheostomy, all this area, nose, mouth, this trachea, all this contains oxygen not taking part in gas exchange. This is wasted ventilation. So when you do a tracheostomy, this part gets decreased, and that's why it decreases the dead space. When you add a mask, it increases the dead space. Is this clear, everyone? This is the best I could explain over here. Okay, as fast as I could. So remember these 2 points. Bag mask ventilation, biggest disadvantage is that it decreases the dead space, but here what you are seeing is a small bachcha log ka mask. Because it's a small pediatric mask, it has a low dead space because it is made for pediatric patients. So compared to the adult mask, compared to a bigger mask, this has less dead space, and that is why it is used for pediatric patients. Last point, contraindicated in patients with tracheostomy? Nahi, it can be used in patients with tracheostomy. That's not a contraindication. Next, a 45-year-old patient with a large neck mass undergoes induction of anesthesia. The anesthesiologist is unable to intubate the patient after multiple attempts and is also unable to maintain oxygenation via mask ventilation. Okay. What is the most appropriate next scenario in management of this can't intubate and cannot ventilate scenario? So attempt intubation using a smaller endotracheal tube, perform an emergency needle or surgical cricothyroidotomy, administer second dose of muscle laxant, or perform emergency tracheostomy. So there is a large neck mass in a patient, all right, unable to intubate the patient. More importantly, after multiple attempts, he is unable to intubate. In this scenario, he is unable to maintain oxygen, means the patient is dying. All right. So what is going to be the answer? The patient is almost dying. You are not maintaining the oxygenation. Therefore, the correct answer here is B. Correctly said by doctor, everyone. Correct, correct. All of you have given correct answers. Absolutely correct. Okay. So perform an emergency needle or surgical cricothyrotomy. See, multiple attempts are made. Will you make another attempt? No. Will you administer second dose of relaxant? इससे तो patient paralyzed हो जाएगा. तो क्या मतलब है देखिए, patient will become paralyzed? No. Will you perform emergency tracheostomy? No, because it will take 15 minutes to do tracheostomy. There may be bleeding. Here you have to intubate, you have to do something immediately. What can be done immediately is emergency needle or surgical cricothyroidotomy. And remember, later on, this has to be converted into tracheostomy. Last year's NEET PG question. It has to be converted into tracheostomy later. Later, not at that time. Into tracheostomy later. Is it clear? Correct, correct. It gains 30 minutes to do tracheostomy. Correct, correct. All of you are correct. Absolutely correct. It is converted to tracheostomy later. So therefore, you're going to do emergency needle or surgical cricothyroidotomy. So basically, when a patient you're handling in emergency, always remember the plan A is ideally always to intubate the patient, right? For a difficult airway, as what they have suggested, na? Difficult airway plan. Difficult airway plan is plan A, intubate the patient. Plan B, use a laryngeal mask airway or intubating LMA or use a fiber optic. If not, then come to plan C, do bag mask ventilation and maintain oxygenation. If you are unable to do that, then come to plan D, and this is needle or surgical cricothyroidotomy. And remember, this gets converted to tracheostomy. This is our difficult airway plan. That's it. Okay, clear? Let's go to the next question. A 55-year-old male is scheduled for a left lung pneumonectomy. To achieve one lung ventilation and facilitate surgical exposure, which of the following is the equipment of choice? Single lumen endotracheal tube, a double lumen tube, laryngeal mask airway, or Giddle's airway? So you all of you know the answer. It's given in the name itself, left-sided pneumonectomy, and you have to achieve one lung ventilation. Can you use a single tube? Because this is a normal endotracheal tube. You can't use it because infection from one side can go on to the other side. For this, the only thing that can be used is a double lumen tube. Double lumen tube has got two lumens. It helps you to isolate the lung, and one lung gets isolated, and it maintains one lung ventilation, means only one lung gets ventilated and maintains one lung ventilation. All right. Laryngeal mask airway, high chance of aspiration, no, absolutely, and this is oropharyngeal airway. Okay, these two are contraindicated there. Why can you use LMA for a surgery? Will not be able to use. So correct answer is B, double lumen tube. Absolutely correct. I got the answers also from most of them. Correct. B. Double lumen tube is correct. So doctor, everyone is given a correct answer, I think. Yeah. Okay, so single lumen endotracheal tube is a normal endotracheal tube. You will not use it. See, anyone's lung surgery is to be done. You put a normal endotracheal tube. Normal tube, if this part of the lung is being operated, all the blood will go on to the other side. You can't protect it. So you use a double lumen tube, it helps you to protect the lung. So what happens in a double lumen tube, one lung can get operated and one lung will get ventilated. That's the whole point. Okay, so that is what is double lumen tube. Laryngeal mask airway stays in the larynx, not important. Oropharyngeal airway stays in the oral cavity, not important. Okay, simple. Next question. What is the correct method of sizing, or what is adequate size of a Giddle or oropharyngeal airway? The same thing. What is adequate size of this airway? Giddle airway. What is the adequate size of a Giddle airway? ठीक है, कहां से कहां तक होता है एडल्ट में? So from the tip of the nose to the tragus of the ear, from here to here. Angle of the mandible to the corner of the mouth. Basically corner of the mouth to angle of the mandible. B. Sternal notch to the chin. Sternal notch to the chin, this part. And interincisor distance. So sternal notch to the chin is basically thigh, almost sternomental distance, that is used for difficult airway. If you will see, this is sternomental distance. This interincisor distance is nothing but mouth opening. These are basically done for airway. These are part of airway examination. How you examine someone's airway? Tip of the nose to the tragus of the ear is for the nasopharyngeal airway. This is oropharyngeal airway, corner of the mouth to angle of mandible. Correct? So therefore the answer is B, angle of the mandible to corner of the mouth. I think most of you have given nasopharyngeal for A. Correct, Dr. Dharmesh. Correct. Good. Well prepared. Huh? Answers I'm getting all good from all of you. Don't worry. And some of the questions are difficult also. Not difficult as in, of course, they're asked in the exam, but this was not a very easy question. This one was also slightly difficult, I think. This one. Okay. But still you guys are able to answer the questions. So these are from the predictor series that we have had. Next question. In an endotracheal tube, what is the function of the Murphy's eye? All of you know endotracheal tube has a small opening. So if this is the endotracheal tube bevel, right, here is the cuff of the endotracheal tube. Right next to here is a small opening. This is what is called as the Murphy's eye. So what is the importance of the Murphy's eye? Right? Does it prevent the cuff herniation? No. Allows ventilation if bevel becomes occluded? Yes, can be. Measures cuff pressure? No. Accidental extubation? No. Correct answer is B. It's a small opening. Okay, it's a small opening which allows for ventilation in case the main bevel becomes occluded. So if here is the trachea of the patient, this is the trachea of the patient, and in the trachea, if I put an endotracheal tube, and this endotracheal tube goes like this, and the bevel gets occluded over here. The bevel has got occluded over here. So in that case, the presence of the Murphy's eye will allow the oxygen from here to go here as well, and from here to go here as well, in case the bevel has got occluded. So therefore, it allows for ventilation if the bevel has got occluded. Okay? So Murphy's eye, correct. Guys, यहाँ पे easy लग रहा है. Do you know the first time when this question was asked in the exam, they had asked you Murphy's eye is related to which of the following? Now all of you are aware. But when the very first time this was asked in the exam, imagine Murphy's eye is related to which of the following? They have written base of skull fracture. ठीक है? Ophthalmic congestion. Third, they had given ENT injury. And fourth, they had given endotracheal tube. If anyone has not studied Murphy's eye, and this comes in the exam, fracture base of skull, ophthalmic congestion, ENT injury and endotracheal tube. Imagine who will mark the answer. And that is why we say many times the answers are not exactly how they come in the exam. Okay, they may have asked something. If someone has, this was the first time how the question was asked. Murphy eye is related to which of the, there's something called as raccoon eye. A lot of people had said this. In fracture head base of skull, there's something called as raccoon eyes. Right, people get confused with that. Okay, so here the answer becomes endotracheal tube. All right, that's how questions come in the exam, to confuse. So be confident. Whatever seems to be your first, play question that you think that comes onto your mind, mark it and don't change your options again and again. A lot of you keep on changing the options, which is wrong. Don't do it. मैं तो ऑप्शन 2 मार्क कर देता. अरे नहीं, वही तो मैं बोला. हाँ, अरे सब लोग वही मार्क करते, वही पॉइंट. अगर कोई नहीं पढ़ा होता तो यही लोग मार्क करते. और राइट, डॉक्टर स्मूथ स्पेशलिस्ट. अरे नाम लिख देते हैं ना अपना, तो आई कैन टॉक योर नेम, आई कैन यूज योर नेम्स ऑल्सो. लाइक डॉक्टर धनुष हैज मेंशन्ड हिज नेम, डॉक्टर धर्मेश हैज मेंशन्ड हिज नेम, डॉक्टर रौनक हैज मेंशन्ड हिज नेम. मैं डॉक्टर स्मूथ स्पेशलिस्ट बोल रहा हूँ. फिर मेरे को बोलोगे नशेड़ी वाला डॉक्टर, बेहोशी वाला डॉक्टर. मैं भी ऐसे नाम रखूंगा अपना. चलो नेक्स्ट वन. A correctly inflated modern endotracheal tube cuff is designed as which type to minimize the tracheal mucosal ischemia? Okay, low volume high pressure cuff, high volume low pressure cuff, uncuffed tube and foam cuff only. Simple question है ये. ठीक है, what is a simple question? आजकल का जो endotracheal tube होता है, that is PVC made up of plastic, and we need to minimize the tracheal damage, ischemia. So what is used is not a low volume high pressure. We want a low pressure basically. So we are using a high volume and low pressure cuff. All right. So what happens is, if this is the endotracheal tube, right, and here is the cuff. So nowadays, let me mark it over here. If this is my endotracheal tube, and here is the trachea. All right. So nowadays the cuff is like this. All right, the cuff is like this. So what happens is, this cuff is basically high volume, but the pressure gets distributed on the tracheal walls like this. It gets distributed. Compared to the old time, in the old time, the endotracheal tubes were like this, where all the pressure was at one point. So if you find, in this case, the volume is less. The volume is less, no doubt. The volume of the cuff is less, but all the pressure comes at one point. All right. So here you have less volume, but comparatively high pressure. On the other hand, what we can see over here is low volume, high volume and low pressure. So this is what is the normal PVC tube nowadays. This is what prevents the damage. Okay. All right. So I've also got an answer. हाँ सही है, डॉक्टर स्मूथ स्पेशलिस्ट, सही नाम लिखा है. डॉक्टर 25 to 30 सेंटीमीटर ऑफ वाटर, करेक्ट, वो भी करेक्ट है. जब कफ प्रेशर होता है, इट हैज टू बी लेस देन 25 to 30 सेंटीमीटर ऑफ वाटर, एब्सोल्युटली करेक्ट. तो आजकल का जो कफ है वो हाई वॉल्यूम एंड लो प्रेशर इज देयर, एंड वी डोंट यूज द लो वॉल्यूम एंड हाई प्रेशर कफ. दीज वर द ओल्ड ट्यूब्स विच वी डोंट यूज एनी मोर. ओके, दीज वर द ओल्ड रेड रबर ट्यूब्स. नाउ डेज वी डोंट यूज देम. Old red rubber endotracheal tubes, we don't use them. Uncuffed tube in adults, no, not used. We used only cuffed tubes. Uncuffed tubes are normally used in pediatric patients less than 6 to 8 years of age. Remember this. Foam cuff is available but not used. Okay. So remember this point, uncuffed tube is not used in adults but pediatric patients less than 6 to 8 years of age. And correctly said, the cuff pressure, absolutely correctly said, cuff pressure should be less than 25 to 30 centimeter of water. Remember, we inflate with 5 to 10 ml of air or saline. लेकिन cuff pressure should be less than 25 to 30 centimeter of water. ठीक है? Next, during direct laryngoscopy, only the epiglottis is visible. माइक्रोकफ इन पीडिया, हाँ माइक्रोकफ यूज करते हैं. ठीक है, अरे भाई लोग, तुम लोग इस पे ध्यान दो ना, टाइप क्यों कर रहे हो, क्वेश्चन पे ध्यान दो. ऑल ऑफ यू डोंट गेट डिस्ट्रैक्टेड, डोंट राइट ऑल दोज मैसेजेस. ठीक है, I mean, I don't have a problem. You can write it, but concentrate on the question ना यार. हम लोग प्रिपेयर कर अपने एग्जाम के लिए, करेक्ट. तो वी जस्ट वांट कि सब कुछ फटाफट फटाफट कंप्लीट कर सके, तुम्हारा टाइम नहीं वेस्ट हो. तो during direct laryngoscopy, only the epiglottis is visible and no part of the glottis is seen. Okay, so what is the Cormack-Lehane grading? Is it grade 1, grade 2, grade 3 or grade 4? Yes, कौन सा grading है? Cormack-Lehane grading, only the epiglottis, okay, and no part of the glottis is seen. हेलो गाइज, मेरे को सबसे हेलो अभी भी आ रहा है, बट ठीक है. हेलो एवरीवन. अरे नहीं यार, मेरा पॉइंट है कॉन्सेंट्रेट करो पढ़ाई पे. आई डोंट वांट यू टू गेट डिस्ट्रैक्टेड हियर एंड देयर. मतलब हाँ, थोड़ा बहुत मस्ती चलता है, बट डोंट वेस्ट योर टाइम ऑन टाइपिंग unless until there's something that you want to ask. You can ask me the question also. तो मोस्ट ऑफ द पीपल हैव गिवन. कितना आंसर लिखा मेरे को डॉक्टर? एक आंसर मिला सी, एक आंसर मिला 4, एक आंसर मिला सी. कौन करेक्ट है इसमें से? खाली एपिग्लॉटिस दिख रहा है. द करेक्ट आंसर इज सी. ओके, ग्रेड 3. रिमेंबर, दिस इज द वोकल कॉर्ड का ग्रेडिंग व्हेन यू आर डूइंग लैरिंगोस्कोपी. हम लोग जब लैरिंगोस्कोपी करते हैं तो वोकल कॉर्ड दिख रहा है कि नहीं. तो लेट मी गो बैक टू एक्सप्लेन द सेम थिंग अगेन. मलम पट्टी में जो हम लोग देख रहे थे ना, let me go back to Malam Patti. So what happens is Malam Patti 1 normally corresponds to the Cormack-Lehane grading. Okay, so this would correspond to Cormack-Lehane 1, Cormack-Lehane 2, Cormack-Lehane 3 and Cormack-Lehane 4. Cormack-Lehane का मतलब होता है on laryngoscope whether vocal cords are seen or not. So similarly, just like in Malam Patti 1 uvula is seen, Cormack-Lehane 1 vocal cord is seen. Cormack-Lehane 2 you can say half vocal cord is seen. Cormack-Lehane 3 only epiglottis seen, only epiglottis, okay, no vocal cord seen. And Cormack-Lehane 4 nothing is seen. Nothing means no epiglottis and no vocal cords, no epiglottis and no vocal cords seen. So that is why this becomes difficult intubation, because vocal cords are not seen. This becomes easy intubation because vocal cords are seen. ठीक है, सिंपल याद हो जाएगा ना. सिंपल ऐसे तो याद करना ना. जस्ट रिमेंबर विद मलम पट्टी, जहां पे यूविला दिखता है वहां पे वोकल कॉर्ड दिखता है. जहां पे यूविला का टिप नहीं दिखता है वहां पे वोकल कॉर्ड नहीं दिखता है. जहां पे सिर्फ बेस दिख रहा है वहां पे एपिग्लॉटिस दिखता है. जहां पे कुछ नहीं दिखता है, कुछ नहीं दिखता है. सेम थिंग, सेम थिंग. मलम पट्टी एंड कॉर्मैक-लेहान. ठीक है, क्लियर? हाँ, मेरे को थैंक यू मिला. थैंक यू सो मच. ओके, just this way. Now don't remember anything else. It must seem vocal cord seen, half vocal cord seen, only epiglottis seen, nothing seen. Done. All right, let's go back. So we were on this part, right? This I've discussed over there. ठीक है, 1 2 3 4 मैं वहां पे डिस्कस कर चुका हूं. Cormack-Lehane grading I have discussed in मलम पट्टी only. Vocal cord, half vocal cord, epiglottis and nothing seen. This is called Cormack-Lehane. Next, 30-year-old female is undergoing laparoscopic cholecystectomy as a daycare procedure. Which intravenous agent is the drug of choice for induction due to rapid recovery and anti-emetic effect? आधा आंसर तो दिया ही हुआ है. ठीक है, सिंपल क्वेश्चन है. डे केयर में एवरीवन नोज द ड्रग ऑफ चॉइस, राइट? रैपिड रिकवरी एंड एंटी-एमेटिक इफेक्ट. करेक्ट आंसर इज एवरीवन नोज. व्हाट इज इट? थायोपेंटोन, प्रोपोफॉल, कीटामिन, इटोमिडेट. डे केयर, द आंसर एवरीवन नोज इज प्रोपोफॉल. Okay, thiopentone is not used in daycare. All right, propofol is the drug of choice. Anti-emetic effect भी है, right? Everyone is correct. Propofol is the correct answer. Correct. Absolutely. Daycare surgery, daycare procedure, drug of choice. Okay, thiopentone is contraindicated for daycare. Right? Propofol has rapid recovery, anti-emetic effect also, fast onset, fast offset. All right. So that's the reason behind it. Next question. ओके, यूज फॉर टीवा, एंटी एमेटिक, एंटी प्रूरेटिक. हाँ, वो सब इफेक्ट है. एंटी एमेटिक भी है, एंटी प्रूरेटिक भी है, एंटीऑक्सीडेंट भी है. ऑलराइट, डे केयर में टीवा युवा सब आएगा. हर जगह देखो ड्रग ऑफ चॉइस प्रोपोफॉल ही होता है. मोस्ट ऑफ द प्लेसेस यू विल फाइंड ड्रग ऑफ चॉइस प्रोपोफॉल ओनली. मोस्ट ऑफ द प्लेसेस. ऑलराइट, अ 25-year-old मेल with bronchial asthma requires emergency surgery. Which induction agent is most appropriate due to bronchodilation and relative cardiovascular stability? Now here there are two things which may be contradictory to each other. That there is bronchodilation also and cardiovascular stability also. But it has been asked this way in the exam and books as well. So the point is you just have to see that this patient is bronchial asthma emergency surgery, you don't have time, and you need bronchodilation. Out of all the options given to you, there's only one bronchodilator, which is good bronchodilator. And answer absolutely correct, all of you, ketamine. The point is, it's a good bronchodilator. Okay. Now, when you compare the pharmacodynamic properties, thiopentone, propofol, no, let me put it this way. When I compare the properties, RS, CVS, CNS of thal, if I take thiopentone, it causes cardiovascular depression, respiratory depression. In the CNS, decreases intracranial pressure, decreases cerebral blood flow, anticonvulsant, इसको बोलते हैं cerebroprotective properties. Ophthal also decreases. If you take propofol, double decrease CVS, more apnea in RS, same as CNS, same in ophthal. If you take etomidate, no change in CVS, RS definitely, RS again it's going to go down. In the CNS, you may get to see focal seizures. Ophthal not important. Ketamine, what you do is just take propofol and make it opposite. Take propofol, make it opposite. It can, right? Here it's bronchodilator, right? It may increase the heart rate, it may increase the blood pressure. So therefore, I'm not saying it totally maintains the cardiovascular stability, but the point is it can maintain the sympathetic tone. That is the point. It maintains the sympathetic tone. All right. And even in the CNS increases, ophthal increases. So that's how you can remember the pharmacodynamic properties. But overall, it's a good bronchodilator, and that's the reason behind it. Okay. ठीक है, ठीक है, ठीक है. सर डॉक्टर भरत से सर कोई ट्रिक बताओ, इनको हमेशा कंफ्यूज. हाँ लिखा तो मैंने, देखो ना, एक ही पेज में भी ट्राई टू रिमेंबर इट. CVS, RS, CNS एंड ऑफ्थेल, राइट. दैट्स द बेस्ट वे टू रिमेंबर इट. ओके. सो थायोपेंटोन स्लाइट डिक्रीज इन एवरीथिंग, प्रोपोफॉल ज्यादा डिक्रीज करता है और भी ज्यादा. इटोमिडेट, CVS स्टेबल, एंड दैट इज व्हाई इटोमिडेट इज कॉल्ड टू बी द वन ऑफ द बेस्ट ड्रग्स फॉर CVS, राइट. Here it becomes the drug of choice for CVS, correct. If you take off CNS, you can use propofol and thiopentone both. Both of them can be used for CNS and ophthal. Drug of choice, both. All right. For respiratory system, you find ketamine, drug of choice. Okay, respiratory system. All right. So that's how you can see. हाँ, और बाकी सब पॉइंट्स सबके ठीक है. कीटामीन में डिसोशिएटिव एनेस्थीसिया भी होता है, सब कुछ इंक्रीज करता है, हेलुसिनेशंस भी होते हैं, करेक्ट. ऑल दोज पॉइंट्स आर एब्सोल्युटली करेक्ट. ठीक है. सो आई थिंक ऑल ऑफ यू आर वेल प्रिपेयर्ड फॉर दैट. सो आई एम नॉट रिवाइजिंग द सेम थिंग अगेन एंड अगेन. लेट मी, बिकॉज देयर आर फ्यू क्वेश्चंस व्हिच आर देयर व्हिच विल नीड मोर डिस्कशन. सो लेट्स गो टू दैट. इफ देयर एनी क्वेश्चंस गाइस, यू कैन आस्क मी इन बिटवीन. ठीक है. नेक्स्ट क्वेश्चन. ओए होए, ये तो मैंने अभी डिस्कस कर लिया. चलो, but anyways, 70-year-old patient with severe valvular heart disease and ejection fraction 25% requires emergency surgery. Which intravenous induction agent provides the greatest hemodynamic stability? Okay, propofol, etomidate, thiopentone, or midazolam? Yes, anyone? Right, डिगेंद्र भाई, एक्सपीरियंस लगते हो कीटामीन को लेके. कीटामीन गुड ड्रग. आज द पेशेंट्स, आज द बच्चे लोग खुश होते हैं कीटामीन लेके, मजा आता है उनको. एब्सोल्युटली राइट. सो एवरीवन हैज गिवन मी द आंसर, which is etomidate. We discussed it before. Etomidate, if you will see, it maintains the CVS. Okay, there's no change. That's what we saw in the pharmacodynamic properties. So everyone has given me a correct answer, and the correct answer is B, etomidate. So remember, here we are discussing, if I have to discuss the side effects, let me discuss that because that's important about etomidate. So etomidate, here patient had severe valvular heart disease, ejection fraction 25%, again emergency surgery. We wanted hemodynamic stability. The answer is etomidate. Propofol would have decreased the CVS, right? Propofol, thiopentone also slightly decrease. Midazolam can also be used, guys, remember, but more than midazolam, it is opioids. Some books have mentioned opioids can also be used for CVS. Can be used for CVS patients. Remember this point. This normally has been asked in INI CET, not in NEET PG, but this question has been asked there also. Okay. So, side effect of etomidate. If someone says what are the side effects of etomidate, remember the side effects of etomidate would be myoclonus and hiccups. All right, it can cause seizures in the patient. All right, which is myoclonus only. So these are the focal seizures. So these are the focal seizures which can be seen. Apart from that, there is adrenal suppression, and it causes maximum nausea, vomiting out of all the agents. ठीक है? All right, maximum nausea, vomiting. Even myoclonus is maximum, guys. So myoclonus, focal seizures, adrenal suppression, and nausea, vomiting. So these are the major side effects of etomidate. All right. So that's about etomidate. Since we're discussing the IV drugs, so as you people have been mentioning ना, तो let me just discuss कि कौन सा drug कहाँ use होता है, how. So for CVS, I'm going to use etomidate. All of you agree with me, and opioids are a good choice. When you speak of a patient, especially for ketamine, if you will say, a respiratory patient who has active bronchospasm, who has got asthma, who's got active bronchospasm, or if you get a pediatric patient or a patient of shunt, tetralogy of Fallot, a patient in shock जिसका BP कम है, all these places I can use the drug ketamine. Ketamine also can be used for out of OT anesthesia. It can be used for full stomach patients. Sometimes it's very useful for short procedures like burn dressings. And yes, a new thing is antidepressant. Right? When you speak of CNS, remember thiopentone is a very good drug, but propofol being a newer drug is preferred or is said to be the same as thiopentone for CNS. When you speak of electroconvulsive therapy, it is methotrexate to be the drug of choice. Rest everywhere else, the answer is propofol. Apart from this, everywhere else, the answer is propofol. Clear? ठीक है? So, CNS में propofol and thiopentone both have equal properties. Some books definitely say thiopentone is better, but propofol being a newer agent, this is normally used nowadays. This is used. No doubt books have said thiopentone is better, but propofol is what is being used. All right. Apart from that, everywhere else the answer is propofol. Whatever else you can think of, where it is a respiratory patient with no bronchospasm, you get a liver patient, kidney patient, daycare surgery. All right, liver patient, kidney patient, daycare surgery, or anything else that you can think of, malignant hyperthermia, porphyria, kuch bhi, anything that you think. One more thing I want to discuss here, thiopentone. When you speak of thiopentone, a common question that comes in the exam regarding thiopentone is that it's a short acting drug. What is the reason for short acting? In fact, all these drugs relatively have a short duration of action. All of them. What is the reason for the short duration of action? In fact, thiopentone is called ultra short. Reason for short duration of action is basically redistribution of the drug from the CNS to the fat or the muscle. बस ये एक वर्ड है जिसके ऊपर लास्ट ईयर का भी क्वेश्चन आया था फ्रॉम थायोपेंटोन. सो बेसिकली इट्स द रीडिस्ट्रीब्यूशन ऑफ द ड्रग फ्रॉम फैट टू द मसल. सो व्हेन आई गिव एन आईवी ड्रग, होता क्या है, आईवी ड्रग जो है दैट गोज टू द सीएनएस. इन द सीएनएस इट कॉजेज जीए. उसके बाद वो फट से बाहर निकल जाता है, इट मूव्स आउट. पर आउट होके वो लिवर में नहीं जाता है, आउट होके वो किडनी में नहीं जाता है, आउट होके क्या हो जाता है, इट बिकम्स रीडिस्ट्रीब्यूटेड टू फैट एंड मसल. एंड बिकॉज ऑफ रीडिस्ट्रीब्यूशन टू फैट एंड मसल, इसका जो जीए का इफेक्ट है वो खत्म हो जाता है. GA effect is over. Because the GA effect is over, therefore it has a short duration of action, and the reason for short duration of action is redistribution. Clear? Clear everyone? ठीक है, that redistribution is an important point. All right. मुझे mention किया था डॉक्टर धनुष ने barbiturates contraindicated porphyria, correct, rapidly distributed, redistributed, डॉक्टर स्मूथ स्पेशलिस्ट. ठीक है. Next question. A patient undergoing induction with thiopentone sodium reports a characteristic taste. Characteristic. Just before losing consciousness, what taste is classically described? A lot of you might have studied or not studied. Metallic taste, garlic taste, sweet fruity taste or salty taste. ठीक है, the answer here is garlic or onion taste. The reason is that it works within 1 arm brain circulation time. So when you speak of thiopentone, I give the drug IV, it goes to the CNS. The time taken for the drug to go from IV to the CNS, this takes 10 to 15 seconds, and this is in general pharma called as 1 arm brain circulation time. So before the patient goes off to sleep, in that 1 arm brain circulation time, suddenly, it's a side effect, this is a side effect of thiopentone, that patient suddenly feels that he's got a garlic taste. Apart from that, okay, so this is one important thing. All right, A is not the answer, B is the answer, garlic or onion taste, right? Dr. Akib Javed has said the answer correctly, B. Okay, so 1 arm brain circulation time जो होता है उसके अंदर it works within that 1 arm brain circulation time within 10 to 15 seconds. So therefore by the time the patient goes off to sleep, GA जब तक होता है तब तक patient gets that taste and the patient tells you, oh, I'm getting that taste, and then he goes off to sleep. Correct? So that is one of the side effects of thiopentone, and the reason is that because it is a very, very fast acting drug, right? It has got a fast onset of action. Fast onset, at the same time in the brain it has only a short duration. It stays for less time and then moves out, which we said is redistribution. ठीक है, fast onset क्यों था? You people had given me the correct answer because it is lipid soluble, it enters the brain very fast. ठीक है, that's the reason behind it. And after that it gets redistributed, redistribution to the fat and muscle. Because of that the patient becomes awake. ठीक है, that's the point. Next question. Minimum alveolar concentration is used to compare the potency of inhalational agents. Which agent is the least potent out of them? So you have got halothane, isoflurane, sevoflurane, desflurane, or highest MAC. So remember, minimum alveolar concentration, basically it tells you the minimum amount of inhalational in the alveoli which produces GA. Okay, if you have to look at the definition of it, it is basically minimum amount of inhalational in the alveoli at which 50% of the patients are unresponsive, ठीक है, to surgical stimulus, are unresponsive to surgical stimulus, मतलब surgical stimulus पे they are not responding. That is the definition, minimum amount of inhalational in the alveoli. So therefore, to remember this, the mnemonic, okay, the mnemonic is, so this tells you dose and potency. Basically minimum alveolar concentration is inversely proportional to potency. Minimum alveolar concentration is inversely proportional to potency, right? More if inversely proportional to potency. All right, so you can remember it as like this. Okay, so you can remember this like MH Maharashtra, IS is Delhi. No, you can use this mnemonic, M for methoxyflurane, so this becomes MH Maharashtra, then IS is D for Delhi, and N for nitrous is no. You can remember Maharashtra is Delhi, no. We'll use the same mnemonic. So what happens is M for methoxyflurane, this is the most potent. N for nitrous oxide, this is not potent or least potent. ठीक है, so therefore ये numbers याद करने की जरूरत नहीं है, एग्जाम में numbers नहीं पूछेंगे. So therefore we are discussing which is the least potent of the ones given below. So as you can see, यहाँ पे nitrous है, फिर des है, then CO, iso and halo. So out of the options given, the least potent here that you can see is desflurane. That is the answer. Okay, so Maharashtra is Delhi, no. एक ये वाला पॉइंट हमने याद किया था. इसी को थोड़ा सा उल्टा करके we can also remember the sequence of onset, which is called as blood gas solubility. So there is something called as blood gas solubility, and blood gas solubility again is inversely proportional to onset and recovery. So we can use the same mnemonic, उसको थोड़ा सा twist कर लेंगे. Let's twist the same mnemonic. Maharashtra is Delhi. ये वाला जो था इसी को twist कर लेंगे. इसको ऐसे कर लेंगे, ठीक है? We have twisted it. Now here what becomes is M for methoxyflurane. This has the slowest onset and recovery. And xenon, this has the fastest onset and recovery. All right. And as I said, how can we remember it? MH is Maharashtra. Okay, we can remember MH as Maharashtra. This is Maharashtra is not Delhi. Expensive. ठीक है, दिस अ स्मॉल वे टू रिमेंबर. उसको उल्टा चेंज कर दिया हमने, बट रिमेंबर यहां पे क्या होता है, नाइट्रस कम्स बिफोर डेसफ्लुरेन. Here you had desflurane coming before nitrous. So remember this point, that's a confusion thing. And nitrous and desflurane have similar values. Alright, so you can remember this onset and recovery also by the same mnemonic of minimum alveolar concentration. Alright. Clear. I think everyone has given me a correct answer. ठीक है, तो याद करने का तरीका भी हो गया. You can remember the potency as well as the onset and recovery of the inhalational agents by this mnemonic, which is similar to both. You can remember the potency as well as onset and recovery. Next one. Which inhalational agent is preferred for smooth mask induction in children because it is non-pungent and minimally irritant to the airway? You guys have given me the answer before. Non-pungent means sweet smelling. ठीक है, sweet smelling, minimal airway irritant. It's not irritant. In fact, this drug out of given from here, what is preferred? It's a bronchodilator. ठीक है, what is the answer then? Is it desflurane, isoflurane, sevoflurane, or ether? Okay, minimal irritant to the airway. The answer is sevoflurane. Okay, sevoflurane. Correct. Everyone has given me the correct answer. Remember, out of them, desflurane has the maximum airway irritation. Ether also can cause airway irritation. Isoflurane as well, okay, but it is got, compared to them, it is less. So sevoflurane is one which is sweet smelling. It's a good bronchodilator. It's the drug of choice for pediatric patients. Okay, it is supposed to be the drug of choice for pediatric patients. Clear? ठीक है. Next question. After discontinuation of nitrous oxide at the end of anesthesia, what is the most appropriate measure to prevent diffusion hypoxia? Stop ventilation for 1 minute, administer 100% oxygen for 3 to 5 minutes, increase nitrous oxide briefly, and give intravenous soda bicarb. Sometimes, even if you don't know the answer, just look at the answer. Something like this, even if you don't know anything what has been mentioned, they have asked you something about hypoxia. What is the most appropriate measure to prevent diffusion hypoxia? Hypoxia means oxygen is going down. So therefore, if oxygen is going down, the point is you're supposed to increase oxygen. Correct. So therefore, out of these options, which is the one that is going to increase oxygen? Option B. That becomes the correct answer. Administer 100% oxygen for 3 to 5 minutes. Stop ventilation for 1 minute means no breathing. Can you do that? Patient का breathing बंद हो जाएगा. No. Increase nitrous oxide concentration. What will help you? No. Give intravenous soda bicarb. Does it help you? No. You just have to give 100% oxygen for 3 to 5 minutes to this patient. That's the correct answer. I think all of you have given me the correct answer. B. Absolutely correct. Okay. Administer 100% oxygen for 3 to 5 minutes. Okay. To the patient. Next. Alright. अच्छा, इसमें है diffusion hypoxia. So wherefore होता क्या है ना, diffusion hypoxia happens during recovery. During recovery from inhalationals. When the patient is getting recovered from the inhalational that we have done, we have stopped the inhalational. So because you have stopped the inhalationals now, right, you have stopped the nitrous oxide, होता क्या है कि there's a huge gush of nitrous oxide. Normally what had happened, the drug had gone from the anesthesia machine to the patient's alveoli. From here it went to the blood, and from there it went to the brain. right? So initially the whole equilibrium was maintained. Then what I did was I stopped inhalational from here. I stopped the nitrous oxide from here. So now everything is there in the brain. It is present in the brain because up to its surgery is getting over, na? So it is present in the brain. I have stopped from the anesthesia machine, but inhalational is still present in the brain. Nitrous is still present in the brain. So when it comes fast into the alveoli, it dilutes the alveolar oxygen and carbon dioxide because there is so much of inhalational, so much of nitrous that it decreases oxygen, it decreases carbon dioxide, and this leads to hypoxia. And that is why it is called diffusion hypoxia. And to prevent that, you stop inhalational and nitrous, but don't stop oxygen. And that is why the point is, don't stop oxygen. You have to give oxygen to the patient 3 to 5 minutes for that. Give 100% oxygen. So once you give 100% oxygen, patient is not going to land up in diffusion hypoxia. Clear? So correctly said, Dr. Dhanush says it's the Fink effect. Absolutely correct. So therefore, this is called diffusion hypoxia, or it is called as Fink effect. Some books have also mentioned it as third gas effect, but no, normally the textbooks don't call it as a third gas effect. Prefer to call it as a diffusion hypoxia or a Fink effect. That's it. Okay. Next question. Shortly after administration of succinylcholine and a volatile anesthetic, the patient develops rapid rise in EtCO2, end-tidal carbon dioxide, generalized rigidity, tachycardia, hypothermia. Every year, they've asked this question continuously for the last 2 years. Every time. I mean, including NEET PG, ionized set also. Right? So you have administered succinylcholine to a patient. Yes. And a volatile anesthetic agent. Suddenly EtCO2 is increased, muscle rigidity, tachycardia, hyperthermia. What is the drug of choice? What will you do? Soda bicarb, dantrolene, calcium gluconate, magnesium sulfate. All of you know the answer correctly. All of you. Absolutely correct. ठीक है, सबको पता है answer. I don't have to say that. It's dantrolene sodium because you're dealing with malignant hyperthermia. This question is very, very important. All right. Malignant hyperthermia is a genetic disorder of sarcoplasmic reticulum. This is a 1 second. It's a genetic disorder of sarcoplasmic reticulum, basically ryanodine receptor gene abnormality. And this ryanodine receptor gene, this is a calcium release channel. So when we give a patient volatile anesthetic agents, succinylcholine or lignocaine, suddenly this is given in the OT. In the OT, when we give this to the patient, volatile anesthetic agents, succinylcholine or lignocaine, suddenly from the calcium release channel, भर भर के calcium निकलता है. There is increased calcium release that takes place. All right. ये जो calcium release हो रहा है, this calcium release which has taken place, all right, this calcium release changes the electrolyte imbalance. All right, can lead to arrhythmias. It leads to increased metabolism. Because of increased metabolism, it increases carbon dioxide production, it increases temperature. Hence, EtCO2 increases, temperature increases, and because sarcoplasmic reticulum is present in muscles, muscles get affected, leading to muscle rigidity. It leads to muscle rigidity, myoglobinuria. The only treatment is to stop calcium release. Only treatment is to stop calcium release. How do you stop it? Give dantrolene sodium. So the treatment of this condition is dantrolene sodium. Clear? Ryanodine receptor, ठीक है. Everyone says the correct sign. EtCO2 step ladder pattern. Correct. Everyone knows the answer. Clear? The answer is dantrolene. Important question. Don't miss it out. One more point. Dantrolene sodium is not only used for treatment of malignant hyperthermia. It is also used. This is last year's ionized set question. Okay. It is also used for treatment in neuroleptic malignant syndrome. It is also used in treatment of neuroleptic malignant syndrome. ठीक है? Remember that. Next question. 45-year-old male with extensive crush injury is planned for emergency debridement. Which muscle relaxant is strictly contraindicated? Don't use it. Which one? Atracurium, succinylcholine, vecuronium, or rocuronium? Answer. Yes. Anyone? What's the answer? Atra, succinylcholine, vecuronium, or rocuronium? What do you think so? No one? Answer is succinylcholine. Okay, correct. Dr. Ronak says B. ठीक है. दिगेंद्र पाल, डॉक्टर दिगेंद्र पाल, सब ठीक है. डॉक्टर धनुष, ठीक है, करेक्ट. सबका आंसर करेक्ट है. सक्सिनाइलकोलिन, एब्सोल्युटली करेक्ट. ठीक है, विच इज स्ट्रिक्टली कॉन्ट्राइंडिकेटेड. सक्सिनाइलकोलिन क्या करता है? ऑल ऑफ यू नो सक्सिनाइलकोलिन इज अ डीपोलराइजिंग मसल रिलैक्सेंट. ऑल दीज आर नॉन डीपोलराइजिंग. Non-depolarizing. This is a depolarizing muscle relaxant. So, when we speak of muscle relaxants, these skeletal muscle relaxants, these are of two types. One is non-depolarizing, the other is depolarizing. The depolarizing are the ones which will cause depolarization and then they will cause muscle paralysis. Non-depolarizing are basically no depolarization, straight away paralysis. Now, because these depolarizing drugs cause depolarization, therefore they work similar to acetylcholine. Because they cause no depolarization, they work opposite to acetylcholine. Acetylcholine का काम क्या था? Depolarization तो है. In a normal neuromuscular junction, the acetylcholine, इसका काम ही depolarization है. All of you know that. Action potential. You guys know that from first prof. Physiology. Alright. So, depolarizing is similar to acetylcholine. Therefore, it will become competitive ki non-competitive. Non-depolarizing is opposite of acetylcholine. So, because non-depolarizing is opposite of acetylcholine, it becomes competitive in nature. Because depolarizing is similar to acetylcholine, it is non-competitive in nature. And that is why the name is succinylcholine, similar to acetylcholine. That's why the name is succinylcholine. This is the only one drug. It is similar to acetylcholine. Here you will get all other drugs. Vecuronium, rocuronium, mivacurium. None of them sound like acetylcholine because they are opposite. Therefore, these drugs, because they are opposite, they work as antagonist at the receptor. These drugs work similar to acetylcholine. Not drugs, only succinylcholine. Therefore, it is agonist at the receptor. Do you realize you get the answer, which they ask you always? That is succinylcholine. Basically, succinylcholine is a non-competitive agonist at the receptor, while all the non-depolarizing are competitive antagonist at the receptor. Clear? Everyone? Clear? Hopefully. I was just trying to take this off X again. Now, when we were discussing when we are discussing about succinylcholine, okay, succinylcholine. All right, we said it is working like acetylcholine, it is causing depolarization. Because it causes depolarization, so whenever there is depolarization taking place, then sodium goes inside, potassium goes outside. Because potassium goes outside, succinylcholine can cause hyperkalemia. Therefore, succinylcholine is contraindicated in any condition which is prone to hyperkalemia. So therefore, what are the conditions where succinylcholine is contraindicated? So anyone having a nerve disorder, neuromuscular disorder, anyone having burns, all right, nerve disorder, neuromuscular, burns, anything with the CNS or brain, all right, spine, massive trauma. In all these conditions, there is increase in the extrajunctional receptors and high chances of hyperkalemia. So therefore, they are contraindicated for succinylcholine. Now, what has been given over here? Extensive crush injury. Extensive crush injury means massive trauma, huge extrajunctional receptors, lots of potassium can come out, it can cause hyperkalemia, and because succinylcholine can cause hyperkalemia, it can cause arrhythmias and death of the patient, and that is why succinylcholine is contraindicated in this patient. Is it clear, everyone? So we've discussed the mechanism of action and the contraindication of succinylcholine also. Okay. Next, in depolarizing muscle blockade, which finding best indicates a phase 1 block on the nerve stimulator? Okay. Is it fade on train of 4 stimulation? This is slightly difficult. You have to understand what they are asking. In depolarizing, remember depolarizing means succinylcholine. Depolarizing means succinylcholine. All right. So in depolarizing, what finding indicates a phase 1 block? Phase 1 block means the normal block of succinylcholine. Remember, succinylcholine has two types of blocks. Normally, this succinylcholine, it gets destroyed by plasma cholinesterase, right? Routinely, what happens is, non-depolarizing, you will give a reversal with neostigmine. Reversal with neostigmine to end the block. You have to give that reversal with neostigmine for non-depolarizing. But in succinylcholine, you don't have to give neostigmine. Nothing has to be given. Plasma cholinesterase will destroy succinylcholine. Because plasma cholinesterase destroys succinylcholine, you need no reversal. No neostigmine, no reversal. This is the normal block of succinylcholine. But if someone has plasma cholinesterase deficiency, in that case, succinylcholine leads to a prolonged block, which is called phase 2 block. Okay. So the point is, succinylcholine has two blocks, phase 1 and phase 2. When there is a plasma cholinesterase deficiency, this is called as a phase 2 block. Normal block is phase 1 block. But when there is a plasma cholinesterase deficiency, it becomes phase 2. क्या होगा? Prolonged block हो जाता है. It becomes increased duration of action, prolonged. But more importantly, in phase 2 block, succinylcholine resembles non-depolarizing block in characteristics. So now, when you speak of a neuromuscular monitor, all of you already know the most common nerve used is the ulnar nerve, and the most common muscle is the adductor pollicis muscle. All this has been asked in the exam. The most common mode is the train of 4, where you give 4 stimuli. So train of 4 means I am giving 4 stimuli to the patient, 1, 2, 3 and 4. This is what I have given to the patient. Each stimulus is of 2 hertz given in a span of 2 seconds, right? If there is no block, no paralysis, I'll get 1, 2, 3, 4. This is normal. This is normal, no block. This is a normal response, no paralysis. In case of a partial paralysis with a non-depolarizing, you get to see this 1, 2, 3 and 4. This is what is seen with a non-depolarizing. This is what is called as fade. This is what is called as fade. In succinylcholine, what happens is you get to see this 1, 2, 3, 4. This is seen in succinylcholine phase 1. All right. Here there is no fade. Remember, succinylcholine in phase 2 is going to produce the same fade because it resembles the non-depolarizing. It shows the same fade. So remember, non-depolarizing and succinylcholine phase 2 both are the same. It shows fade. Just have to look at this and then answer the exam from this point. So, which finding best indicates phase 1? In a phase 1 block, do you get to see fade? No. Fade is seen only in two conditions. Fade is seen with a non-depolarizing block and fade is seen in phase 2 block, not phase 1. No fade. Yes, this is correct. You are going to get no fade. Reversal by neostig mean, this is not related over here. Post technique facilitation, it is some other mode. It is not train of 4. It is not train of 4 mode. It is tetany mode. Tetany means this, what you have studied in first prof, methods of stimulation. So the correct answer here is no fade on train of 4 stimulation. That is the answer. Okay. So this is what is seen. Fade normally is seen in non-depolarizing and phase 2 block. Okay. This much is sufficient. No too much details. Next, which non-depolarizing muscle laxant undergoes Hoffman's elimination, making it preferred in hepatic and renal failure? Okay, which one? Which one? Which non-depolarizing undergoes Hoffman's elimination, making it preferred in severe hepatic and renal failure? Is it rocuronium, vecuronium, atracurium or pancuronium? Yes. What would you prefer? Roc, vec, atra or pancuronium? Correct. Absolutely correct. Atracurium. This undergoes Hoffman's elimination. Correct. Everyone has given the correct answer. Correct. Atracurium. Atracurium, this basically Hoffman's elimination is non-enzymatic, non-organ dependent degradation. Non-organ dependent degradation. Non-organ dependent degradation. Okay, it is based only on temperature and pH. So Hoffman's elimination is basically based on temperature on pH. It is based on temperature and pH. It is based on temperature and pH. ठीक है? Clear? All right. So, because it is non-enzymatic, non-organ dependent, just based on pH and temperature, so it does not dependent on any organ, and that is why it's not dependent any organ for degradation. That is why it becomes the drug of choice for hepatic and renal failure. Not just that, also preferred for a pediatric and neonate. Not just severe hepatic and renal patient. This is also used in pediatric and neonates. Same reason. All right. Remember, rocuronium is a drug which increases the heart rate. It's a painful injection. It's a painful injection. Vecuronium is the most cardiostable. Pancuronium increases heart rate, increases the blood pressure. Remember, the problem with atracurium otherwise is that it can cause histamine release. Histamine release. And because of histamine release, it can decrease the blood pressure. It can cause flushing. The second problem with atracurium is that it can form a metabolite ludanosine. Accumulation of ludanosine can cause seizures, and therefore we have cisatracurium. Cisatracurium, the importance is that there are less levels of ludanosine and there is no seizure. At the same time, there is no histamine release. Okay, that's why cisatracurium is a better drug than atracurium. All right. This again has been asked in the exam regarding hypotension, flushing and histamine release. Recent question. Let's go to Sugama-Dex. Next question. Sugama-Dex till now has not been asked in FMGE, but last year it has been asked in NEET PG as well as INI set. Okay. So Sugama-Dex reverses rocuronium induced neuromuscular blockade by which mechanism? Inhibition of acetylcholinesterase, direct antagonism of the nicotinic receptor, encapsulation and inactivation of the rocuronium molecule, and competitive inhibition of sodium channel. Inhibition of acetylcholinesterase. This is basically acetylcholinesterase inhibitor, and this is basically then going to be your neostigmine. This is the mechanism of action of neostigmine. Neostigmine is basically anticholinesterase. Neostigmine, the mechanism is to block the destruction of acetylcholine, and therefore the point of neostigmine is it increases acetylcholine. That is what neostigmine does. All right. Direct antagonism of the nicotinic receptor. No, direct antagonism means it is basically your non-depolarizing drugs. Vecuronium, rocuronium, they are going to directly antagonist at the receptor. Okay. Encapsulation and inactivation of rocuronium molecule. Yes, it encapsulates and inactivates the rocuronium molecule. This is the mechanism of action. And competitive inhibition of sodium channel. No, this is the mechanism of action of local anesthetics. Okay, remember that's also asked in the exam. Competitive inhibition of sodium channels is the mechanism of action of local anesthesia drugs. So Sugama-Dex, guys, remember, Sugama-Dex basically leads to a Sugama-Dex, it leads to a fast reversal. It leads to a fast reversal, which otherwise, especially with rocuronium, right? And it can work for rocuronium more, it can even work for vecuronium, and even they say for pancuronium. All right, it leads to a fast reversal, is basically is a specific reversal agent. It's a specific and special reversal agent. The advantage is that it is not increasing acetylcholine. When you give neostigmine to a patient, the problem is that it increases acetylcholine everywhere in the body. All right. But when you give Sugama-Dex, it just basically, if this is a rocuronium molecule, what Sugama-Dex does is Sugama-Dex will go, it will encapsulate it. This is Sugama-Dex. And it forms a complex. And this complex is then thrown away from the body. All right. This complex gets thrown away from the body, out of the body, and therefore you don't not playing with the acetylcholine. It just will going to form a capsule. It will encapsulate and throw it away. That's why it is one of the best drugs to be used nowadays, and that's the reason why nowadays many places you will find they say rocuronium is the drug that is used for daycare surgery also. Fast reversal as a muscle relaxant. It's used for daycare also because it causes fast reversal. In the past, we used to study for daycare muscle relaxant used was succinylcholine or mivacurium. But nowadays they say succinylcholine is not something which can be used or should not be used. Better than that is to use rocuronium. It causes a fast reversal. Okay. Then talking about neostigmine. Neostigmine is administered with glyco. If there are any questions, guys, try to ask me. Dr. Dhanush says cyclodextrin molecule non-steroidal. Correct. All that is correct. Absolutely. Okay. Neostigmine is administered with glycopyrrolate during reversal of non-depolarizing blockade. What is the primary purpose of glycopyrrolate? It prolongs neostigmine, prevents neostigmine-induced bradycardia secretion, or enhances Hoffman elimination, provides post-op analgesia. So enhances Hoffman is wrong. You know it. Provides post-op analgesia is wrong. You know it. Neostigmine is given with glycopyrrolate. So glycopyrrolate will prolong neostigmine? No. What is the correct answer? It takes care of the neostigmine induced bradycardian secretions, what we just saw. Remember, here the mechanism of action is, if you will see, non-depolarizing drugs, they are opposite of acetylcholine, and that's why they are competitive in nature. The meaning of competitive means whichever is strong gets to sit on the receptor. So if vecuronium is strong, it will get to sit on the receptor. If acetylcholine is strong, that will sit on the receptor. So therefore, what happens is that normally if this is the receptor and we have given a good dose of vecuronium, so the vecuronium is stronger than acetylcholine in terms of the dose. In that case, vecuronium sits at the receptor, the sodium does not go inside, and therefore there is no depolarization. And till the time vecuronium is sitting at the receptor, you are getting a muscle paralysis. On the other hand, when we had spoken about succinylcholine, what had happened was when succinylcholine sits at the receptor, it works like acetylcholine. So the gate opens, sodium goes inside and potassium goes outside, which was causing hyperkalemia. Correct? That was the problem with succinylcholine. And after that, succinylcholine was not getting destroyed and then it stays on the receptor. Right? It sits on the receptor and that causes, after depolarization, there was paralysis. After depolarization, then paralysis. And therefore, here it was nothing to do with acetylcholine because it is actually working like acetylcholine. So it was plasma cholinesterase coming from the plasma and destroying succinylcholine and taking it away after 5 to 8 minutes. And that is why succinylcholine is said to be the shortest acting muscle relaxant. Okay. Now for vecuronium, what to do? Remember, vecuronium is competitive. The one which is stronger gets to sit at the receptor. So therefore, what we used to do is we give neostigmine. Remember, neostigmine point, what does it do? Neostigmine basically blocks cholinesterase. What is the function of cholinesterase basically? Normally, acetylcholine gets destroyed by acetylcholinesterase and it goes back to synaptic vesicle. If I give neostigmine to a patient, it blocks acetylcholinesterase, increases acetylcholine. The increase of acetylcholine at the nicotinic receptor makes acetylcholine more than vecuronium, and this can sit at the receptor now. This is called reversal because acetylcholine has become more than vecuronium. But the increase of acetylcholine also takes place at the muscarinic receptor. When acetylcholine increases at muscarinic receptors, it leads to muscarinic side effects. Remember all the muscarinic side effects, dumbbells and all. So that is increase in frothing, increase salivation. All of you have said correctly, huh? There is frothing, salivation, increased sweating, lacrimation, bronchial secretions, right? But there is bradycardia, there's and bronchospasm. Okay, there is bradycardia and bronchospasm. So whenever you give neostigmine for reversal, this is what you get in the patient. Okay, so whenever you give neostigmine to the patient, this is what we get. And therefore, because there is bradycardia going to take place, there is going to be secretions and sweating. That is the reason to counteract it, we add atropine or glycopyrrolate. That's why add glycopyrrolate or atropine to neostigmine to take care of these side effects. Is it clear? Everyone? Add glycopyrrolate or atropine to neostigmine for this. Thumbs up. ठीक है सबको? All okay? Next. A patient develops prolonged apnea, right, after administration of succinylcholine. The most likely underlying cause is deficiency of which enzyme? We just discussed acetylcholinesterase, pseudocholinesterase, monoamine oxidase, or cyclooxygenase. Which one you think? Acetylcholinesterase has got nothing to do with succinylcholine. All right, monoamine oxidase, no, we just saw. A prolonged apnea, correct, is pseudocholinesterase deficiency. We've discussed this also, right? Because it gets destroyed by plasma cholinesterase, and if a patient has this deficiency, in that case, this 5 to 8 minutes can become 5 to 8 hours. Prolonged block, that is what we had seen here also. Prolonged block, can you see this? If someone has plasma cholinesterase deficiency, it increases duration of action, prolonged block, and that is seen in plasma cholinesterase deficiency, where it resembles the non-depolarizing block. It's a phase 2 block. Okay, so the same thing we have discussed here also. All right, so the correct answer here is plasma cholinesterase deficiency. I think all of you have given me the correct answer. Correct. B. Everyone is set. Correct. Next. During spinal anesthesia, this question exactly was asked almost like this in the present INICT 2 weeks back, 3 weeks back. Okay. If you can check my YouTube videos also, right? Exactly in the recall session that we've had, exactly the same way. Exactly the same way. 1-2 points were changed here and there, but this exactly was asked in INICT. Arrange them in the sequence. I'm not saying the questions are picked up from here, but I'm saying normally the points remain the same. They just twist the questions. All are PYQs and PYTs. Normally it gets twisted here and there. Of course, there are few new questions which come. No one can say which are going to be the new questions, and no one can predict that this question is going to come. All right. But the point is we have to be prepared for the exam. Our topics have to be clear. And normally it's your PYQ and PYTs that you need to be aware of. Okay. So here they're discussing spinal anesthesia by the midline approach. What is the correct sequence of the layers pierced from superficial to deep? So outside is going to superficial is going to be skin, right? And deep is slowly going inside. So skin, interspinous, supraspinous, first one, ligamentum flavum and then dura. So interspinous does not come after the skin immediate and then supraspinous. This is wrong. Skin, supraspinous, interspinous, ligamentum flavum. This is correct. After the skin, you will not get ligamentum flavum, right? And here up till here it's correct, but after the ligamentum flavum there is no interspinous ligament. So the correct answer is B. Okay, so remember, if you are going like this in the patient, this is the posterior part, this is the anterior part of the patient, all right, and we are going from the superficial to deep, all right, from posterior to anterior. The first layer you get is the skin, then comes the subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum. As soon as you cross ligamentum flavum, we come to the epidural space. Okay. So skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum. We cross ligamentum flavum, we come to the epidural space. After that, epidural means outside the dura. So the next space is dura. After the dura, immediately is arachnoid. Okay, so this dura and arachnoid are together, almost stuck onto each other. And after the arachnoid, we get the subarachnoid space. Okay, so I've written dura and arachnoid too much. Let me make it short. Dura is a small space over here, very small. Dura and arachnoid are stuck onto each other, almost. And then you get this subarachnoid space. Remember, subarachnoid space is what contains CSF. This is where we give spinal anesthesia. Epidural is given over here. This is where we give, this is a negative pressure space. Okay, it's a negative pressure space. Potential space है basically at negative pressure. Alright, this is where we give epidural. This time they'd ask subdural. Where is subdural? The area between dura and arachnoid. This is basically called as subdural. Okay, the area between dura and arachnoid is what is called as subdural. So these are the various layers that you get. The site of action remains the same, whether it is for spinal or epidural. So if there is a spinal cord over here and the nerves are coming like this, okay, so the site of action remains the same. In spinal anesthesia, the effect takes place from within the CSF on the spinal nerve. In epidural, it takes place from the epidural space. That's the only difference. It's working on the same spinal nerve, but in spinal anesthesia from within the CSF and in epidural from the epidural space. Okay, so these are the various layers. Hopefully you have understood, all of you. ठीक है, ये layer समझ में आ गया होगा सबको, right? Any questions and doubts you can ask me, right? So skin, subcute, supraspinous, interspinous, ligamentum flavum, then epidural space. So you can remember like this. There is first two. The first that you get is 2S, which is skin and subcute. Then you get 3L, which is supraspinous, interspinous and ligamentum flavum. 2S, 3L. After that, ligamentum flavum. So the last one is ligamentum flavum, which is F. Alright. After F comes E, epidural space. After E comes D, which is the dura. After that, what you should have got is C and B. बट BC हम लोग करते हैं, तो क्या बच गया A. and after that A, the last one then becomes your subarachnoid space. All right, and instead of that BC, what is left over there is the subdural space. Okay, and this would become your subdural. This becomes the subdural. Clear? So that is how you can remember these layers. Clear everyone? ठीक है, ये हो गया layers. Next, after spinal anesthesia, a patient develops hypotension due to sympathetic blockade. What is the most appropriate first line management in the operating room? Yes. Is it Trendelenburg position, rapid intravenous fluid bolus and vasopressor as needed, immediate intravenous diuretic, or stop the oxygen therapy? Patient has developed hypotension. Patient has developed hypotension due to sympathetic blockade. Correct. He develops it, which is right. Correct. Now, first line, Trendelenburg means you're going to do a head low. If you do a head low, remember our drug is containing dextrose, it is going to go back further. So in a head low position, the level is going to go up. Do you want that? Is that needed? The patient already has hypotension. Why do you want it? Nothing is going to go. Correct answer, all of you have said correctly. Intravenous fluid bolus and vasopressors as needed. The vasopressors which we can use. Okay, you can use phenylephrine, which is the best one. We can use ephedrine. Phenylephrine, we can use ephedrine, mephentermine. Even books have mentioned adrenaline. Right? Remember, head low has been mentioned correctly. Books have mentioned head low also. Right? So it's not that Trendelenburg position. No, Trendelenburg तो उल्टा हो गया. Reverse Trendelenburg होता. Sorry. ये उल्टा हो गया. Had it been the other way around, had they mentioned head low, had they mentioned head low, separate this way, head low position. So if they had mentioned head low in one, ideally they have said even this is basically head low position is correct. Why? Because they say if you do a head low position, the venous return to the heart increases. Right? Why hypotension had taken place? Hypotension took place because there was sympathetic blockage. There was blockade, right? The sympathetic block that led to vasodilation in the lower limbs. This led to peripheral pooling. Because of peripheral pooling, the blood from the heart, it has gone to the legs. Correct? Therefore, the heart becomes empty. Because the CVS becomes empty, it leads to, I'm giving a layman language. Huh? This is not what is given in books. CVS and empty. It's not given in books. Okay. So, because the CVS becomes empty, you are supposed to give IV fluids. Okay. That is the reason we give IV fluids. And we give vasopressor to take care of the blood pressure. Because in all the patients, there are going to be peripheral pooling of blood. And vasopressor is used. Alright, so IV fluid is going to take care of the heart which has become empty, and therefore that's the reason why we use IV fluid. But at the same time, the books have mentioned because there is peripheral pooling of blood. If you do a head low position, the blood from the heart, there's going to be an increased venous return, and this also takes care of it. So therefore, head low position in case given is also correct. It's not wrong. Apart from that, intravenous diuretic doesn't make any sense, and stopping oxygen therapy doesn't make any sense. So correct answer is rapid intravenous fluid bolus and vasopressor as needed. Okay. Then a patient develops postural headache 24 hours after the spinal. If conservative measures fail, what is the definite treatment? Okay. Oral paracetamol, epidural blood patch, intravenous furosemide, or intrathecal steroid injection. Simple. What is the most definite? All of you already know. The most definite answer is basically epidural blood patch. Okay. Oral paracetamol can be used. Yes, but that is not. These are basically the first line treatment. Intravenous furosemide, no. Intrathecal steroid, no. Basically what happens is, for postural headache, this is basically we are dealing with post-dural puncture headache. As we were discussing with the spinal needle before, what happens is you are basically puncturing the dura. So the dura gets punctured at one point, right? Here is the dura. All right. Here is the dura. So our dura and arachnoid are kind of joined together. So when you're putting a needle inside, what we are doing is we have punctured the dura and it leaves a dural hole. So from this dural hole, what happens is the CSF which is inside, okay, this CSF starts to come out, okay, because the CSF starts to leak, CSF leaks, and this is the reason for the headache. This is the reason because the CSF is leaking. Apart from that, there is vasodilation also. So the reason of post-dural puncture headache, the reason for that, PDPH, the reason for PDPH is the vasodilation plus the CSF loss or the CSF leak which has taken place. Okay, it's because of that. Now, because of vasodilation, you can give cerebral vasoconstrictors, and for CSF loss, you're just trying to compensate for it. Therefore, the first line of treatment will involve giving caffeine to the patient, coffee. It will involve giving theophylline to the patient. It takes care of as a cerebral vasoconstrictor, theophylline. These are the first line treatment, right? This happens on postural variation, means when the patient is sitting, that time it increases. When the patient is lying down, it is normal. So therefore, when the patient is straining, it increases. So you're supposed to give stool softeners also. Of course, there are analgesics you will give. You will maintain hydration. All this is given. Stool softeners are given. Okay, all these drugs are given. Stool softeners also. Now, apart from that, when the routine, these are the first line treatment. When the first line treatment fails, what do you do? In that case, what I do, I take 10 ml of patient's blood and I put it in the epidural space. Because there is a CSF leak from here, I take 10 ml of the patient's blood and I put this blood in the epidural space and I seal this area. It forms a clot over that area, it seals it, but the only point is it is invasive, and therefore this is the most definite treatment, but it's the last treatment. So the last treatment is epidural blood patch, and this epidural blood patch forms a clot. It forms the clot and seals the dural rent. The dural rent or the hole from where the CSF was leaking. Okay? Clear? It stops the CSF leak. Correct, correct, absolutely correct. Correct answer there, Dr. Digendra Pal. Correct, absolutely correct. Next, during epidural anesthesia, the epidural space is most commonly identified using which technique? Hanging drop technique, routine standard, loss of resistance technique, transillumination, and ultrasound Doppler of epidural veins. What will you do? Ultrasound Doppler doesn't make any sense. Okay, transillumination. ट्रांस कहीं और यूज होता है, यू गाइस नो इट. कहाँ यूज होता है ट्रांस इल्यूमिनेशन टेक्निक? ठीक है, you guys know this trans illumination technique. You know ultrasound Doppler also. All right. Hanging drop, can it be used? Yes, it can be used. But loss of resistance is the most common. Therefore, the answer is loss of resistance. Hanging drop can also be used. It's not wrong. This can be used. But loss of resistance technique is the most common used technique. Why? Because it is a negative pressure space. Correct. I think all of you have given me the correct answer. All of you. Everyone is correct. Everyone. I can see them. It gives way. Yes. More than that, I'll tell you the reason. If you see, when I was discussing, it's a negative pressure space, na? So that's the reason behind it. What's the meaning of a negative pressure space? Negative pressure space means it contains air. Imagine it's like a balloon filled with air. So if I take the epidural needle, it contains air or saline, and I try to push it. Wait. I'm not having an empty bottle. Otherwise, I wanted an empty bottle. Okay, chodo. So the point is, if it's an empty bottle and I'm trying to, kind of having a syringe which contains air or saline and try to push it over there, suddenly it gets pulled inside. Okay, it kind of gets pulled inside, and what gets pulled inside is because of this negative pressure space that it is there. It's a negative pressure space. Because of this negative pressure space, it pulls it in. That is called loss of resistance to air or saline. That's the most common method. And the reason is because it's a negative pressure space at subatmospheric pressure. Okay, so reason is since it's a negative pressure space, it's basically a potential space. You will not call it a negative pressure space. Basically the ideal word is it is a potential space at subatmospheric pressure. At subatmospheric pressure. Okay, it's a potential space at the subatmospheric pressure. That's the point. Next. All right, so that's the reason behind it. And hanging drop is also correct, but loss of resistance is the most common. They had asked you the most common used technique for epidural. Okay, that's the reason. Now, in Bayer's block, intravenous regional anesthesia, which local anesthetic is preferred due to safety profile and common exam usage? Okay, common usage basically, right? So, which local anesthetic? Bupivacaine, remember, is the most cardiotoxic. Most cardiotoxic. Tetracaine, it is the second longest acting. It's basically long, second longest acting. Tetracaine is second longest acting. This is second longest acting. Okay, is that okay? Now, out of them, what is left now? Dibucaine. Dibucaine, remember, is the longest acting. When you are, answer is lignocaine. When you are giving intravenous regional anesthesia, it means regional anesthesia is given IV. Regional anesthesia means I'm injecting the local anesthetic drug. So I'm injecting the local anesthetic drug IV. So therefore, if you give it IV, there is a high chances of the systemic toxicity. Systemic toxicity, high chances, because there are high chances of systemic toxicity. Therefore, a drug like bupivacaine is contraindicated because it is the most cardiotoxic. So what you do is you give the drug IV, but at the same time you attach a tourniquet. Therefore, always remember local anesthetic is given IV, but a double cuff tourniquet is attached. Double cuff tourniquet is attached so that your drug does not go. So when you use a double cuff tourniquet, the maximum time you can use a tourniquet is up to 1 hour. So you need a block which lasts up to 1 hour, plus you need to use a drug which is not very long acting and wide margin of safety. So when you speak of drugs, there are only 2 drugs that you can use. So for this reason, we want to use drugs which have wide margin of safety. Wide margin of safety. So wide margin of safety means the therapeutic index. You know, na? Wide margin of safety means one dose which is needed for the effect and the dose for therapeutic, for the toxicity. Wide margin. There are drugs with narrow margin of safety. You must be aware. Narrow margin of safety means lithium, there must be valproate, lithium, valproate, magnesium. All these are narrow margin of safety. Lithium, digoxin, valproate, magnesium, okay, even aminophylline. These drugs are narrow margin of safety. Means these drugs can have complication anytime, even near the therapeutic dose. But if you will see drugs like lignocaine and prilocaine, they have relatively from local anesthesia, they have got wide margin of safety, and that's why lignocaine or prilocaine is used. They are going to work only for 1 hour. All right. Where to apply the tourniquet? हाथ पे ना, tourniquet कहाँ पे? हाँ, तभी तो कहाँ यूज होता है? Because you have to supposed to use the tourniquet. It is used only for upper limb and lower limb surgery, that too lasting up to 1 hour. ठीक है? You cannot having for the neck ना. Neck tourniquet मतलब गया patient. Okay. So therefore it can be used only for a upper limb or a lower limb surgery. Okay. Double cuff tourniquet is attached. Clear? हो गया? Next, a patient presents with severe muscle rigidity, opisthotonus, risus sardonicus. एक सेकेंड, ये तो गलत हो गया, रुक जाओ, ये आधा क्वेश्चन गलत है, ये टाइप, ये दूसरी जगह से टाइप हो गया, इसको छोड़ दो. What is the maximum recommended dose? ये तो मैं सोचा ये कहाँ से आया यहाँ पे. ये तो मेरा क्वेश्चन नहीं है. Now is the question. ठीक है. Now okay everyone. All right. एक्चुअली इसका जो बीच का था ना वो मिस हो गया. बीच का जो पूरा सेंटेंस था वो मिस हो गया. फॉरगेट अबाउट दिस यार. द पॉइंट इज यू जस्ट हैव टू आंसर दिस क्वेश्चन. जस्ट रिमेंबर दिस, ऑल दिस पॉइंट इज रॉन्ग. ये सब हटा दो. ये पॉइजन हम डिस्कस नहीं कर रहे हैं. इसको यहाँ से हटा देते हैं. ये हटा देते हैं. वेट, टेक दिस ऑफ. What is the maximum recommended dose of lignocaine with adrenaline for infiltration anesthesia in healthy adult? Is this okay now? Correct. With ADR, what is the maximum recommended dose of lignocaine with ADR for infiltration anesthesia in healthy adult? I think I got the answer already. Yes, Dr. Ravi Ranjan Rai, correct, and Dr. Digendra Pal as well. सब लोग सबने correct answer दे दिया. Perfect भाई. Good. Very nice. 7 milligram per kg is the correct answer. Remember, when you use plain lignocaine, the maximum dose of plain lignocaine is 4 to 5 milligram per kg. Normal lignocaine, 4 to 5 milligram per kg. But if I am using lignocaine plus adrenaline, remember the dose is up to 7 milligram per kg, which means lignocaine adrenaline is much more safer drug than plain lignocaine. Okay. Why is that? Because it causes vasoconstriction. Okay. So lignocaine normally is 4 to 5 milligram per kg. Normally what happens is local anesthetic drugs are vasodilators. Normally all local anesthesia drugs are vasodilators. Because of being vasodilator, there are two problems. What will happen? The effect will be less because more drug will go in the blood vessel. Remember, I am injecting the local anesthesia drug inside the tissue, and in the tissue these drugs are vasodilator. So therefore, being vasodilator, what will happen? They will dilate the blood vessel. So therefore, more drug is going to go in the blood vessel, right? And less drug is going to be there on the effect on the nerve. So if you will see, local anesthesia per se is going to decrease the effect on the nerve. You will see, being vasodilator, the effect on the nerve is less because it's the inherent property. But if I use lignocaine plus adrenaline, what will it do? It is going to cause vasoconstriction. So because of vasoconstriction, this vasodilation becomes constriction. Because of vasoconstriction, I am going to get less drug in the blood vessel, and I am going to get more drug on the nerve. So if I am going to get less drug in the blood vessel, it means less systemic absorption of the drug. If there is less systemic absorption of the drug, means less complications in the patient. If it is less complications means in the patient, it means the maximum dose can be more than the otherwise. And therefore, normal lignocaine you can use only 4 to 5 milligram per kg because the drug is a vasodilator. And therefore, because of causing vasodilation, there can be high chances of toxicity. Since it is vasodilator, lignocaine, plain lignocaine is vasodilator, right? On the other hand, lignocaine ADR has become a vasoconstrictor. Because it has become vasoconstrictor, I can use more dose. It's going to cause less complications comparatively. Okay, I hope you've understood this. Now, during a peripheral nerve blockade, okay, a patient develops perioral numbness, tinnitus, metallic taste, agitation, and then seizures. What is the specific antidote that should be administered immediately? Is it intravenous phenytoin, 20% lipid emulsion or intralipid, intravenous naloxone, or intravenous protamine? So if you know, protamine out, okay, protamine is out. Peripheral nerve block, there is perioral numbness, there is tinnitus, metallic taste, agitation, and then seizures, which means you are dealing with that systemic toxicity of local anesthesia drug. Okay, peripheral nerve block means I've injected the local anesthesia. So the local anesthesia has been injected and this has led to local anesthesia systemic toxicity. Remember, local anesthesia systemic toxicity, normally you get CNS symptoms before the CVS symptoms, except for bupivacaine. Right? In bupivacaine, you get both of them together, almost together. CNS and CVS both happen together with bupivacaine. In bupivacaine. Alright. So now intravenous phenytoin will take care of seizure. So forget that. It is basically 20% lipid emulsion because this is used for the treatment of bupivacaine toxicity. It is like a chelating agent. Right? Intravenous naloxone. Naloxone, remember, it's for basically opioid. It's an antidote for opioid. Alright? Clear? So opioid toxicity, if there is there. In fact, this time naloxone was also asked in INICT. That's covered in my questions in recall also. You can check. Naloxone. Opioid toxicity, pinpoint pupils, patient not breathing. That question was asked in INICT. The answer was naloxone. Okay. Here we are discussing with local anesthesia systemic toxicity. The patient develops perioral numbness, tinnitus, metallic taste, agitation, and then seizures. All right. So therefore, the treatment is going to be treatment of the bupivacaine toxicity, 20% lipid emulsion. It's like a chelating agent. It will bind the molecules of bupivacaine and take it away. It's called a lipid sink theory. Right. It sinks all the lipid. It is called lipid sink theory. You don't need to know so much details. But it's a lipid sink theory. It forms a sink where it collects all the lipids, deposits them, and takes it out. Like Sugamadex. Like Sugamadex. Remember, this works like Sugamadex. No, it's not exactly the same encapsulation, but you can think in terms of like Sugamadex. Like Sugamadex takes hold of rocuronium, takes it away. Similarly, emulsion, this will catch hold of bupivacaine and take it away. All right, so that is what is used as a treatment. Now, a ventilated patient under GA develops a capnogram with upsloping alveolar plateau. Shark fin appearance, everyone knows this. What's the most likely cause? Esophageal intubation, bronchospasm, cardiac arrest, or exhausted CO2 absorbent. Everyone knows shark fin appearance is basically nothing but, which is the answer? Bronchospasm. Okay, it's bronchospasm. Esophageal intubation would lead to something like this and then a flat line. Bronchospasm would lead to what is called as the shark fin appearance. Cardiac arrest is going to be a flat line. Exhausted CO2 absorbent would lead to a step ladder pattern. Okay, this would lead to a step ladder pattern. All right, this is going to lead to a step ladder pattern. So yes, everyone is correct. B is the answer. Okay, bronchospasm. Okay, remember whenever we discuss capnography, so in capnography, this graph which goes up. All right, so there are 5 points which are important: A, B, C, D, and E. So this is slightly different over here. All right, so this graph will start like this. From here, it goes slightly here, slightly up here, and then goes down. So these are the points which we get to see. This is point A, this is point B, this is point C, this is point D, and this is point E. A to B, guys, basically is baseline. A to B is baseline plus dead space. Remember, B and C is basically alveolar gas plus dead space. C to D, this is alveolar gas only plateau. And D to E is the inspiration. This point D is EtCO2, end-tidal carbon dioxide. This basically is the maximum alveolar carbon dioxide. Okay, so this is your graph normally, and that is how it comes. So whenever the graph goes up, it indicates expiration, and the graph going down, it indicates inspiration. A graph going up indicates expiration, and whenever it goes down, it indicates inspiration. And that is why when you get a graph like this, it indicates inspiration during expiration. Inspiration during expiration, which means patient is out of muscle relaxant effect. And it means spontaneous breathing of the patient. It means spontaneous breathing of the patient. Okay? Clear? I think I've discussed that. Let's discuss now carbon monoxide poisoning. So there are around 7-8 questions, I think. Yeah, 1, 2, 3, 4. Hard we finished of 5 only. I thought 7-8 are there. 5. 1, 2, 1, 2, 3, 4, 5, 6. Huh. I was saying 7-8, but 6 questions are there. Okay, just 6 questions and we'll be done. Next question. In carbon monoxide poisoning, pulse oximetry SpO2 readings are often falsely normal or high, mainly because of which reason? A lot of you would say, sir, we have not read it, we don't know the answer. Read the option. Many times the option gives you the answer by itself, right? What is the question? What is the answer? In carbon monoxide poisoning, pulse oximetry readings are often falsely normal or high due to which reason? The device directly measures PaO2. उसका कार्बन मोनोक्साइड से क्या लेना देना है? नेल पॉलिश इंक्रीजेस ट्रू आर्टेरियल ऑक्सीजन कंटेंट, कोई मतलब है? क्या लेना देना है? You are going to get confused with two things. You are going to get confused with carboxyhemoglobin is interpreted as oxyhemoglobin and methemoglobin. Here we are talking about carbon monoxide. How can carbon monoxide, when this is carbon monoxide, will lead to presence of what? Carboxyhemoglobin or methemoglobin? Okay. It is going to lead to carboxyhemoglobin. Methemoglobin is not going to be the answer. So the answer becomes A, as correctly said by all of you. Carboxyhemoglobin is interpreted as oxyhemoglobin by standard pulse oximeters, and that is why you get a falsely high reading. And therefore, we should not be using a standard pulse oximeter, but we use something called as co-oximeter to measure this. Okay, not pulse oximeter, but co-oximeter. Clear? ठीक है? Easy. Next. Pin index safety system prevents the wrong gas cylinder attachment. What is the pin index for oxygen? Simple. Very, very simple. All of you know the answer. Oxygen. 15, 25, 35 or 26. 15 is for what? 15 is air. 35 is what? Nitrous. 16 and 26 is carbon dioxide. So what is the correct answer here? Everyone knows the answer. You have said it correctly. All of you have said it correctly. Yes, it is 25, which is oxygen. Okay, so remember carbon dioxide can be 16 or 26. It prevents the wrong. Correct. Absolutely correct. All of you have given the correct answer. Absolutely, I'm sure about it. Okay, I've seen that. So it prevents the wrong pipeline attachment. Sorry, gas cylinder attachment. Air is 15, oxygen is 25, nitrous is 35, and carbon dioxide is 16 or 26. So this is our pin index. Okay, 35 is for nitrous. Next question. In a standard cylinder color coding used in anesthesia equipment, which color is associated with the carbon dioxide cylinder color? So, what is the color? Blue, green, black body with white shoulder. Remember, black body with white shoulder is oxygen. Blue colored is nitrous. What is the answer? Gray. Okay, carbon dioxide is gray in color. All right. Not green, but you can get one question where they ask you gray body with black and white shoulder. So when you get a gray body with black and white shoulder, here the answer is air. And in case they ask you blue with white, remember this is going to be Entonox. Entonox basically is a combination of nitrous oxide plus oxygen. That's why you get blue with white in color. Clear? So yes, gray is the answer. Everyone has mentioned correctly. The answer is B. Correct. Now, the second gas effect seen with nitrous oxide administration is best explained by which of the following mechanisms? Nitrous oxide decreases alveolar ventilation. The rapid uptake of nitrous oxide concentrates the second inhaled anesthetic in the alveoli. Nitrous oxide increases cardiac output, and nitrous oxide directly increases MAC of volatile agents. Second gas effect. What is second gas effect? It decreases alveolar ventilation? No. It increases cardiac output? No. Right? Second gas means, as the name suggests, rapid uptake of nitrous concentrates the second inhaled gas in the alveoli. This is the correct answer. It increases the concentration of the other gas. Correct? That's the meaning. So nitrous oxide has got those three effects. If you remember, diffusion, hypoxia. So there are three alveolar effects of nitrous oxide. One is concentration effect, which is nitrous oxide increases its own concentration. Second is the second gas effect. where nitrous oxide increases concentration of co-administered gas. And the reason for that is because there is a rapid uptake which concentrates the other gas. Okay, it increases the concentration of co-administered gas. And the third, of course, that we had discussed was the Fink effect, the diffusion hypoxia. Do you remember that? Fink effect or diffusion hypoxia, we've already discussed that. ये हमारा हो चुका है, ठीक है, क्लियर. Fink effect और diffusion hypoxia, rapid uptake says डॉक्टर रवि रंजन राय, डन. ठीक है, सब लोग करेक्ट बोल रहे हो. Then we come to second last, है ना, almost done. Second last question. So as I said, I try to finish off within 2 hours. 2 घंटे में almost खत्म हो गया हमारा. A healthy 25-year-old male posted for elective hernia repair with no systemic illness is classified under ASA physical status. What grading? ASA 1, ASA 2, ASA 3 or ASA 4? It has been mentioned there is no systemic illness. अगर कोई systemic illness नहीं है तो प्री एनेस्थेटिक चेकअप में हम लोग इसको क्या बोलेंगे? ASA 1. रिमेंबर, ASA 1 is the correct answer. No illness, normal healthy patient. Normal healthy patient. If there is someone having a mild systemic abnormality तो ASA 2 हो जाता है. Normal healthy is ASA 1. Okay. Mild systemic illness, or you can say it or controlled illness, is ASA 2. Or controlled. If the illness becomes severe and it becomes uncontrolled, it is ASA 3. If it is severe, uncontrolled and it becomes threat to life, it is ASA 4. ठीक है, जैसे नॉर्मल पेशेंट विथ हाइपरटेंशन वो ASA 2 रहेगा विच इज कंट्रोल्ड. बट अगर हाइपरटेंशन बढ़ गया, अनकंट्रोल्ड हो गया, तो ASA 3 बन जाएगा. वही हाइपरटेंशन विद मायोकार्डियल इस्कीमिया बिकम्स ASA 4 और एंजाइना, थ्रेट टू लाइफ. और ASA 5 होता है मॉरिबंड पेशेंट नॉट एक्सपेक्टेड टू सर्वाइव विदाउट सर्जरी. मॉरिबंड पेशेंट मतलब मरने वाला पेशेंट. मॉरिबंड पेशेंट not expected to survive without surgery. With or without surgery. ठीक है. एंड ASA 6 बोलते हैं ब्रेन डेड पेशेंट को. ठीक है, ब्रेन डेड पेशेंट. क्लियर. नॉर्मल प्रेगनेंसी ASA 2, हाँ करेक्ट है. अनकंट्रोल्ड बोला, ठीक है. सीवियर इलनेस ASA 3, ठीक है, सबने करेक्ट बोला है. करेक्ट आंसर. आई थिंक यू हैव नोइंग ऑल दिस. क्लियर. लास्ट क्वेश्चन देखते हैं. अकॉर्डिंग टू स्टैंडर्ड प्री ऑफ फास्टिंग गाइडलाइंस, व्हाट इज द मिनिमम फास्टिंग पीरियड रिकमेंडेड फॉर क्लियर लिक्विड्स बिफोर इलेक्टिव सर्जरी इन एडल्ट्स? 1 hour, 2 hour, 4 hour, 6 hours. Remember, they are saying for clear liquid. For always remember, 2 hours is basically for clear liquids. ठीक है, so correct answer is B. 4 hours is for breast milk. 4 hours is for breast milk. All right, 6 hours is for any light meal. Any light meal or other types of milk. Right? And remember, 8 hours भी एक होता है, that is for heavy meal. चिकन, मटन, पनीर. तो therefore a point ये है कि अगर 6 और 8 दोनों हुआ है तो क्या चूज करोगे? For routine surgery, 6 hours और 8 hours क्या चूज करेंगे? So remember, if 6 and 8 both are given, I will choose the option 6. I will not choose 8 because no one will tell you that कल तुम्हारी सर्जरी है तो eat chicken, mutton, paneer and come. सुना आज तक कि tomorrow is your surgery, eat chicken, mutton and come. Tomorrow surgery, so tonight have chicken. No one will say that. They will always say have a light meal, and therefore when you have a light meal, the ideal answer is 6 hours. Also, let me put one more point. It has not come in the textbooks yet or in the guidelines, but nowadays they say for a pediatric patient for clear liquids even 1 hour. In fact, even for adults they say even 1 hour can be correct for pediatric as well as adult to a clear liquid. Yes, but as of now, don't go for that 1 hour. Maybe that 1 hour will come after some time. But for right now, what is given in books, let's consider it 2 hours. ठीक है, 2 घंटा. Remember, हाँ सब लोग हंस भी रहे हैं. करेक्ट. 8 hours वैसे थोड़ी होता है. कभी सुना है किसी को बोलते हुए कल तुम्हारी सर्जरी हो रही है, आज चिकन मटन पनीर खा के आना कल रात को. कल तुम्हारा एब्डोमिनल सर्जरी है, पता नहीं खाने को मिलेगा कि नहीं, मटन खा के आओ. कोई नहीं बोलता है. Okay, so if 6 and 8 both are given, then keep the answer as 6 is what I would suggest. Okay, and ideally 1 hour वाला भी अभी तक गाइडलाइन में नहीं आया है. Okay, so Dr. Som Subhadra says aspiration. हाँ यार, let me tell you one thing. See, aspiration के chances ना कभी भी कम नहीं होते हैं. Now let me talk about physiology. Even if you are fasting, do you know even when we are fasting, our salivary secretion, saliva, it gets secreted at 1 ml per kg per hour. Am I right? Even when you are fasting, right? And even when you are under anesthesia, सब कुछ. और gastric secretion जो होता है, gastric secretion, it happens at 6 ml per kg per hour. But overall, if you will see, the stomach is never empty. Stomach is never empty. Salivary secretion और gastric secretion चलता है, तभी तो glycopyrrolate दिया जाता है ताकि secretions कम हो सके. Right? So saliva and gastric secretions are always getting there. So no doubt. But the point is, when there is aspiration going to take place, that is the reason when you want the patient to be fasting, because aspiration becomes dangerous if it increases that more than 25 to 30 ml. It contains particulate matter and it is highly acidic. The Mendelssohn syndrome. The problem, remember, with Mendelssohn syndrome, that is where it becomes problem. And hence, whenever you give general anesthesia, it is always said the best thing is to intubate the patient so that you can decrease the chances of aspiration. And that is why इसीलिए तो हर patient को intubate करते हैं GA देने के बाद. Right? Intubate क्यों किया जाता है? Because it's said to be the safest to prevent aspiration. Once you put an endotracheal tube, not only it maintains patent airway, it protects the airway from aspiration. ठीक है? That is why you intubate the patient. Clear? Hopefully, I'll not take more time of you, but this much. Any questions and doubts you can ask me, guys. Otherwise, thank you for joining me. A lot of you had joined. ठीक है? You answered all the questions, and I think you are well prepared. सब लोगों ने अच्छा आंसर दिया. Hardly I found people doing any mistake. ठीक है? So you guys are well prepared. Keep your calm and coolness for the exams. Okay? Any questions and doubts you can ask me. I'll share my Telegram ID and my number with you. So my Instagram ID is Instagram. I'm sharing with you. That's my Instagram ID. It is Dr.Vinish, the one with the guitar. मेरा शक्ल दिख जाएगा तुमको गिटार बजाते हुए. All right. और दूसरा I'll give you my number as well. You can take it down, and any questions you can WhatsApp me to my number. Okay. Don't worry. All the best, guys. Okay. So I'm sharing my Instagram ID and I've shared my WhatsApp number, so you can send questions to me if there are any doubts that you have. And thank you everyone. So I get thank you from all of you. Dr. Som Subradas, Digendrapal. Thank you so much everyone. Thank you so much. Okay, कोई questions or doubts होंगे तो please पूछ लो. Otherwise you can follow me on Instagram, ask me questions there or on my WhatsApp. Okay, all the best. Do well. And when you pass, let me know. So you have my Instagram ID, you have my number. When you guys clear, do let me know. I would love to hear from all of you. Okay, कोई और question तो कुछ नहीं पूछ रहा है तो bye bye बोलते हैं. Okay, no other questions. ठीक है. All the best, guys. Do well. Bye. Bye.